I love coming back here. It's a lot of fun for me. It allows me to talk about really my favorite topic in the entire world, and it's great to have you guys here today. Welcome and good afternoon to everybody. I hope everybody got their ice cream, so you're ready, you're pumped, you're excited to talk about allergy and immunology. All right, so without much further ado, we'll go ahead and get started. All right, so why is allergy and immunology important to you? Okay, well, it's important to you because it's important to the American Board of Pediatrics, right? If you look at, the percentage of questions that's in the American Board of Pediatrics, you'll see that allergy and immunology comprises about 3.5% of all the questions on there. Now, that may not seem like a whole lot, but if you compare it to the other subjects, it's quite a significant amount. So if you look at GI, it's about 3.5%. Endocrine, it's also about 3.5%. Cardiology is only 3%. Renal is only 2.5%. And of course, growth and development, it's always been a focus and emphasis of the ABP. So that's about 5% of your questions. So allergy is very important. You're going to see a lot of questions on it. So let's get started. All right. So I'm going to divide it up into different sections. We'll talk about the immune system. We'll look at the innate immune system versus the adaptive immune system. We'll talk about some of the players that are involved in the immune system, these different cells. We'll talk about HLA. We'll talk about antibodies and complement. Finally, with that sort of basic understanding of immunology, we'll go over the different types of immunodeficiencies, and I'll group it up into B-cell defects, T-cell defects, combined defects, phagocytic defects, and complement disorders. We'll then move on and talk about hypersensitivity reactions, the Jelen-Coombs, type 1 through type 5 reactions. And then we'll talk about specific allergic disorders, including anaphylaxis, urticaria angioedema. I won't spend too much time on asthma because you guys got a whole entire section from pulmonary medicine, so we'll just kind of breeze over asthma, although it's also one of my favorite topics as well. We'll talk about allergic rhinitis, atopic dermatitis, food allergies, adverse drug eruptions, latex allergy, and insect allergy. And then we'll talk about other immunological disorders as well, too. So this is kind of the summary and the framework for today's talk. All right. So first, a lot of people give me feedback that, why do you make immunology so complicated? Right? It's not that it's complicated. It's because there's so many different players and there's so many different terms and the language is so different. So I'm going to try to break down the different language and the different terms for you. And we need to start off with a basic understanding of immunology in order for you to answer the questions correctly on the American Board of Pediatrics, right? Because they're not going to give you a simple question like, for example, what do patients with chronic granulomatous disease infections get, okay? They know you're too smart for that. They're not going to give you that type of question. What they're going to do is they're going to give you a child, for example, who presents with such and such infections. And then you're going to have to work your way backwards to figure out what's the diagnosis and what test to order in order to establish the diagnosis, okay? And that's really how reality works, right? A patient doesn't come to your office and with a big old sign on their head says, I have leukocyte adhesion defect. Okay, what are you going to do for me? It doesn't work that way. The reality is patients are going to present with infections, and then you're going to try to figure out, based on your basic understanding of immunology, how to approach this patient. What are some things that I should think about in terms of immunodeficiency disorders in order to establish a diagnosis for this patient? Okay, so that's why it's important to at least get a basic understanding of the immune system. Okay? So first, the immune system is typically divided into the innate immune system and the adaptive immune system. The innate immune system is rapidly acting, it's nonspecific, it has no memory. It consists of players such as complement, macrophages, and natural killer cells. The adaptive immune system, in contrast, is much slower to respond. However, it's very, very specific, and it allows for memory, meaning that the next time this pathogen invades the host, the adaptive immune system can remember and recognize it quickly and establish a defense for that pathogen. So The adaptive immune system can further be divided into the humoral adaptive immune system and cell-mediated. The humoral players include B cells, plasma cells, immunoglobulins. The cell-mediated players, if you will, include T cells, activated macrophages, and activated natural killer cells. Now, what makes them so different? Well, what makes them different are their receptors. The innate immune system have these generic, kind of ready-made receptors that kind of are able to recognize, in general, a type of pathogen. It allows for like a quick but non-specific response. So an example of that is your toll-like receptors. So these toll-like receptors are on your kind of your primitive innate cells. And for example, toll-like receptor 3 can recognize certain patterns on bacteria, for example, such as gram-negative bacteria or the lipopolysaccharides, okay? So they can recognize it very quickly and generate a response to these gram-negative bacteria. So this allows for a quick but non-specific immune response. The adaptive immune system, however, have very custom-made receptors. These include your T cell receptors and your B cell receptors. These receptors are refined, they're very specific, and they're able to recognize almost an infinite variety of pathogens. So you can kind of think of the innate immune system as the first responders in an attack. They can recognize kind of common generic microbial patterns, such as your LPS, and they can kind of recognize a group of pathogens, for example. Okay, so the innate immune system is your first responders, and then they provide signals for the adaptive immune system to respond. So I'll give you kind of a scenario. You have macrophages, which are part of your innate immune system. Okay, they can recognize, again, going back to the LPS example, with their toll-like receptors, these gram-negative bacteria. They engulf the bacteria. Then they provide signals to T cells, which are part of the adaptive immune system, to generate a more sophisticated, robust response. Now, there's a lot of overlap between the two immune systems, right? So there are cells that initially function as part of the innate immune system, but later on can play a role in the adaptive immune system. So for example, your macrophages and your natural killer cells can initially function as part of the innate immune system, but they can become further activated by T cells and now become part of this more robust adaptive immune system response. And then there are these sort of hybrid cells, these sort of innate-like cells. They are kind of in between the innate immune system and the adaptive immune system. They are rapid-acting, but less specific. Okay? So examples of these include your delta gamma T cells, which are primarily located in your GI tract, something called natural killer T cells, and also your B1 cells, which are innate-like versions of your sort of conventional B cells that we all kind of know and hear about. So this is kind of the overview of the immune system. You've got your lymphoid cells, which you can divide into your lymphocytes, your B cells, and your T cells. Your B cells include your B1 cells, your B2 cells, which are your conventional B cells, and your marginal cells. Okay? Then you've got your T cells. You've got your alpha-beta T cells, your typical CD8, CD4 T cells, and we have those delta-gamma T cells, like innate-like T cells that I talked about earlier, which are primarily found in the GI tract and your mucosal tract. And you've got your natural killer T cells as well as your regular natural killer cells. You've also got a population of myeloid cells, granulocytes, neutrophils, eosinophils, basophils, and a host of other cells that are part of the immune system. Okay. So this is kind of just a nice schematic diagram of some of the players in the immune system. So you can kind of look at, these are your innate cells, okay? And these are your adaptive cells, okay? And then these are your innate-like cells, okay? So this is kind of the framework, the players in the system that we all should kind of recognize and kind of know a little bit about. Now let's take a step back. Now in allergy and immunology, we always talk about CD this, CD that, and what in the heck do you mean by CDs, all right? Usually when we say CD this, CD that, people say, I'll see you later, okay? So what CDs stand for are clusters of differentiation, Okay? So what they are, they're like name tags on cells, all right? It allows us to recognize what type of cell they are, okay? So for example, if a cell has CD20 on it, okay, then that's a name tag that this is a B cell, okay? If a cell has CD56 on it, then it's a name tag that this is a natural killer cell. If a cell says CD4, everybody knows about your CD4 cell, right? That's a helper T cell. Or CD8, that's a cytotoxic T cell. So these are name tags on cells that allow us to kind of differentiate which cell is which. Okay? Now, what about ILs, interleukins? Okay? Interleukins are the language of the immune system. Okay? It allows one cell to tell another cell what to do. So for example, if a cell secretes something such as IL-10, it tells the immune system to, hey, let's calm down. The infection is over, let's calm down, and we don't need to be so aggressive in terms of our response. So these ILs will tell different cells within the immune system family what to do. This is your HLA or MHC, or your human leukocyte antigen. And what MHC, or major histocompatibility complex, does is it allows the body to differentiate between self and non-self, okay? It's encoded on chromosome 6, and there's 3 classes of HLA antigens, 1, 2, and 3. So let's go over class 1, HLA, or human leukocyte antigen. This is found in pretty much all your cells except for your mature red blood cells, right? And cytotoxic T cells, again, that name tag, CD8 T cells, recognize antigen only when it's presented by this class 1 HLA. So here's your sort of a diagram, all right? Your MHC1 is on any cell, okay? Now there's a T cell receptor, okay, on your cytotoxic or CD8 positive T cell, which can attach and bind to antigen that's presented by your MHC1 molecule, and that's stabilized by the CD8 antigen. So this interaction is very important for the immune system to sort of differentiate self versus non-self. What about class 2 HLA antigens? So HLA class 2 include your HLA DP, DQ, and DR, and they're only found in antigen-presenting cells. So what are antigen-presenting cells? These are cells that include monocytes, macrophages, dendritic cells, Langerhans cells, and B cells. So what does it mean, antigen-presenting cells? Well, antigen-presenting cells is exactly that. They take up antigen and they present it to T cells. So that's what they are, okay? So these CD4 T cells can only recognize antigen when they're presented by these antigen-presenting cells that have class 2 HLA antigens on their cell surface. And there's a diagram of CD4 and your MHC class 2 on your macrophage or antigen-presenting cell. Okay. So then it comes to this whole concept of HLA restriction, and I said it already. Your CD8 or cytotoxic T cells can only recognize antigen when it's presented correctly, that is, in the context of a class 1 HLA antigen. Okay? And then your CD4 or helper T cells can only recognize antigen when it's presented correctly, and that in that case, when the antigen is presented by a class 2 HLA antigen. Okay? So that's the whole concept of MHC or HLA restriction. All right, so nice easy way to remember, 8 times 1 is 8, 4 times 2 is 8. Okay? All right, so now let's look at T cells. What do T cells do? Okay, what's their function? All right, so one, they're able to destroy intracellular organisms, okay? And they also help in regulating antibody production by B cells. The T cell receptor can recognize an almost infinite variety of different protein antigens when it's presented in the correct context of the MHC molecule. It's always associated with something called CD3, which is a signal that is something that's required for signal transduction. So all T cells have to have this CD3 on their cell surface. Now you can divide T cells in your CD4 or helper T cells and CD8, which are your cytotoxic T cells. Your helper T cells or CD4 T cells provide defense against extracellular pathogens. There's 2 different subsets, your Th1 subset, which induces cytotoxic T cells and leads to cell-mediated immunity. Your Th2 subsets induce B cells to produce antibodies and provide humoral immunity. Okay. Your cytotoxic T cells provide defense against intracellular pathogens and also tumor surveillance against neoplastic cells. All right, let's move on and talk about natural killer T cells. Okay? So recognize that natural killer cells are able to recognize lipids and glycolipids in the context of an MHC-like molecule called CD1. That's why it's a natural killer T cell. And why is it a natural killer T cell? Well, it has CD16 and CD56 as a name tag on its cell surface. Therefore, it is a natural killer cell. Okay? It has innate-like properties, so it kind of has both innate and also adaptive properties. Now, there's something called T regulatory cells. So after you have an infection, how are you able to sort of turn down the immune response? Well, you need these T regulatory cells because what they do is they regulate the immune system. Okay? The expression of a transcription factor called FOXP3 controls the development and function of T regulatory cells. And its function is to, again, suppress and regulate the immune system. And they secrete cytokines and interleukins, like I mentioned before, IL-10, for example, and TGF-beta to calm the immune response down. Okay, so that's immune speak for suppress. So after you've got immobilized your adaptive immune system, your innate immune system, and the infection is clear, you have to have a way to kind of calm it down, to say we've got the infection under control, we don't need the immune system keep on going. And that's the purpose of these T regulatory cells. So when you don't have these T regulatory cells, right, what happens is you get autoimmunity. You have constant activation by the immune system, and you actually get autoimmunity. Natural killer cells. Natural killer cells are our innate immune response to tumors and viruses. Again, they express CD16 and CD56. That's why they're called natural killer. Okay? So why do they come into being? Well, cytotoxic T cells, or your CD8 T cells, are responsible for killing viruses. However, through evolution, viruses have sort of found a way to escape detection from your cytotoxic T cells. Remember I told you before that your cytotoxic T cells can only recognize antigen if there's an MHC1 associated with that antigen, right? So viruses are smart. What they do is then once they invade the host cell, they actually turn off the machinery to produce MHC1. So if you turn off MHC1, these cytotoxic T cells can't recognize that there's something wrong. So they leave that cell alone, the virus continues to divide and replicate in that host cell. So our immune system came up with another idea of having natural killer cells. Now these natural killer cells are always in kill mode. So basically what it is our own cells need like an identification card to say that, hey, it's one of us, that everything's okay, and so for these natural killer cells not to kill that host cell, okay? So they have something called HLA, our host cells have something called HLA-E. So when viruses turn off MHC production, it also turns off HLA-E production. These natural killer cells come by and kill off that infected host cell. Okay? So it allows for our own immune system to detect that something's wrong where the cytotoxic T cells couldn't because of the virus, turning off that MHC1 production. Okay? Now B cells, what do B cells do? Well, there's two functions of B cells. One, they produce antibodies, right? And they also act as antigen-presenting cells and present these antigens to your helper T cells. Okay. So antibodies are composed of 2 heavy chains and 2 light chains. There's 5 isotypes that you all know. There's IgM, IgD, IgG, IgE, and IgA. And they function in terms of opsonization, meaning that they coat the bacteria with the antibody, allowing for macrophages to come by, eat up that bacteria, and get rid of it. Okay? They can also neutralize toxins and also neutralize viral particles as well too. And finally, antibodies can cause complement activation. Okay? So this is the structure of an antibody. Okay? You've got your antibody region, your variable region, and your FC region. The FAB region is kind of the variable region where it can bind to different antigens. The FC part is the constant region. Okay? That's where we determine whether it's a type IgG, IgA, IgM, IgE, or IgD. Okay? So let's go over the different classes of antibodies. So we'll start off with IgG. IgG is the main antibody in our serum. Okay? It's the major antibody in our immune response. There's 4 different subclasses. There's IgG1, IgG2, IgG3, and IgG4. IgG readily crosses the placenta, and maternal antibodies are able to protect the infant until 4 to 6 months of age. Okay? So do you guys know why most babies don't get ear infections until about 4 to 6 months of age? Right, because of Ig. Actually, during the 3rd trimester, okay, there's actually active transport of the mom's IgG into the baby. Okay, so when the baby's actually out, they actually have higher IgG levels than the mom. So there's active transport of IgG to help the baby out while its immune system is starting to develop. All right. However, IgG has a half-life of about 4 weeks. So if you consider that it takes 4 to 6 half-lives to kind of go down to the nadir state, that's why babies have their Ig nadir at about 4 to 6 months of age, and that's when they can start having ear infections at that time because they're no longer protected by the mother's antibodies. Okay, so that's really important to know. IgG can also activate complement as well too, so that's another important function of IgG antibodies. So IgM. IgM is the first immunoglobulin produced in an infection. So this is really useful because it allows us to differentiate between an acute infection versus an infection that has occurred before, or a chronic infection. Okay? IgM is secreted as a pentamer. Okay? There's 5 monomers that are attached together by a J chain. Because there's 5 of them, it's the best antibody for complement activation. So this is what IgM looks like. Again, there's 5 of them all attached together by a J segment. Now, IgA is the main antibody or immunoglobulin found in our secretions or our mucosa. So, of course, it's very important for mucosal defense. It's secreted as a dimer, meaning that there's 2 of them attached together with a J chain and a secretory component. Okay? And it's secreted in breast milk, right? So do you guys know why mothers kiss their babies and dogs lick their puppies? Oh, it's because they're surveying the pathogen flora in their babies, right? So when they do that, they can build up a response and produce appropriate IgA and then provide IgA through breast milk to the baby or to the puppy. So that helps the baby, not only they're getting IgG through transplacental transfer initially, but then afterwards they get IgA antibodies through the breast milk. Okay. Now, one thing to note is IgA does not activate complement, right? And why is that? Why don't you want IgA to activate complement? Well, remember, IgA is primarily found in the mucosal surface, right? So it's found in the respiratory tract, but also in the GI tract. Well, what's in the GI tract? You've got all these foods, right, that are foreign, that's in the GI tract. You don't want IgA activating complement in your GI tract. That would be horrible, right? So it'd be like explosions going on in your GI tract. So you don't want that. So that's why IgA does not activate complement, okay? So this is what IgA looks like. Again, it's the main secretion in breast milk, and it's a dimer, and it's attached together with a connecting J chain. Okay, so IgE, it's the lowest, has the lowest concentration in the serum, but it's the bane of allergist existence, right? Because it's involved in all kinds of allergic reactions, but also historically, it's also played a role in fighting parasitic infections as well too. Right? And this is what it looks like, IgE. Right. I'm just going to spend very quick time talking about complement. It's very complicated. There's a whole cascade that you really don't need to know, but you just kind of have general concepts about. So there's 3 different pathways for complement activation. There's the classical complement activation pathway, mannose binding pathway, and then also the alternative pathway. They all kind of come together and produce something called the membrane activating complex, okay, or MAC. And what MAC does is it pokes holes in bacterial cell walls. So anytime you have a complement factor deficiency, you're not able to poke holes in these bacterial cell walls. So now with that in mind, and I've shortened the immunology portion as much as I can to sort of give you sort of a basic understanding of immunology. Using that, now we're going to talk about all the different immunodeficiencies. Well, not all of them, because there's about 300 of them. We don't have time to talk about 300. We're going to talk about the main ones. I'm going to categorize it into specific groups so it facilitates a better understanding. So we're going to divide them up into adaptive defects and innate defects. Within the adaptive defects, you've got B-cell deficiencies, T-cell deficiencies, combined B and T-cell deficiencies. Okay? On the innate side, you've got phagocyte disorders, toll-like receptor defects, and complement disorders. Right. So the first question is, when should you, as a pediatrician, suspect that there is actually something wrong with the immune system? Okay? So this slide is actually from the Jeffrey Model Foundation for Primary Immunodeficiencies. And you should suspect a primary immunodeficiency when that child has any of the following. If they've got any 2 or more of the following. If they've got more than 4 ear infections in a year, okay, 2 serious sinus infections a year, and I'm talking about real bacterial sinus infections, not just like, oh, has a little runny nose and a little bit of headache. That's not a sinus infection, okay? This is a real bacterial sinus infection. If that child has required more than 2 months of antibiotics with little effect, if they've had more than 2 pneumonias in a year, if they have failed to thrive, if they have recurrent deep organ abscesses, okay, if they've got persistent thrush, okay, on their mouth or in their skin, if they need IV antibiotics to clear up infections, if they've had 2 deep-seated infections or septicemia, and then finally, if you've got a family history of a primary immunodeficiency, because we know a lot of our primary immunodeficiencies have a genetic etiology. Okay. The next thing you want to do is you want to try to think about which arm of the immune system is affected. Is it a problem of B cells? Is it a problem of T cells? Is it a problem of phagocytes? Is it a problem with complement? Right? And now I'm going to give you the tools on how to do that. So first of all, what are the type of infections that cause that B-cell defects are vulnerable to? Okay? So whenever you see recurrent sinopulmonary infections, think about B-cell defects. Okay? So that includes if they get recurrent sinusitis, recurrent otitis media, recurrent pneumonias. That's what you want to think about, B-cell defects. And why is that? The reason for that is because you got these conjugated bacteria, Streptococcus pneumonia, H. influenza, and Staph aureus. If you don't have the correct antibodies, if you don't have IgG or IgM, your immune system isn't going to be able to get rid of these bacteria, okay? The other thing that patients with B-cell defects are susceptible to include viruses such as enterovirus, because there's no IgA, okay, production. And they're also susceptible to protozoan infections such as Giardia, because again, there's no IgA and IgE. So if you've got somebody that can't produce IgG, IgA, IgM, and IgE, these are the types of infections that they're vulnerable to. Okay? So if any child presents with this, you want to think right off the bat, this is probably a B-cell defect. Okay? All right. What about T cells? What kind of infections do you think about for patients with T-cell defects? Okay? So T cells are responsible, remember, for intracellular defense. So these patients with T cell deficiency will have problems with intracellular organisms, and they're going to have problems with opportunistic infections, right? And what are those, right? You think about bacteria, salmonella, syphilis, mycobacterium, MTB, MAC, MAI. Think about viruses within the herpes family of viruses, CMV, HSV, varicella, EBV. Think about fungal infections such as Candida, aspergillosis, cocci, crypto, and histo. And then you want to think about other protozoa such as PJP, formerly known as PCP, toxoplasmosis, isosporiasis, and microisosporiasis. Okay? So this is a long list of a lot of different pathogens, right? But what's kind of the common kind of theme? My analogy is this, is think about patients with HIV, right? Because HIV is really the epitome of an acquired T cell defect, right? And so actually when HIV just came on the scene, the initial folks who treated HIV were actually pediatric immunologists, because these are the same type of infections that they saw with their congenital T cell defect patients, right? So you think about HIV, right? What do they get? They get PCP, right? They get aspergillosis, they get CMV, retinitis, CMV colitis, they get MTB, tuberculosis, right? These are all the things that HIV, an acquired T cell defect, get. The same thing happens to congenital primary immune deficiency patients with T cell defects. So that's something that you can kind of remember, and it's easy to remember. All right. What about patients with both combined B cell and T cell defects? What do they get? The answer is everything. They just get everything, right? Because they've got no T cells, they've got no B cells. So in your vignette or in your clinical practice, if you have a kid who has all kinds of different infections, they've got a combined T cell defect, okay? What about phagocyte disorders? What are some things that you should think about when you're suspicious for a phagocyte disorder? Okay? So they're going to have skin and organ abscesses, right? They're going to be susceptible to Staph aureus. They're going to be susceptible to catalase-positive organisms like Serratia, aspergillosis, weird organisms like Chromobacterium, Burkholderia, and Nocardia, okay? So anytime you have on your vignette that says Chromobacterium or Nocardia, think about phagocyte disorders, specific chronic granulomatous disease, which we'll get into in a little bit. What about complement disorders? What are the types of infections that these patients get? Well, they can get overwhelming sepsis, okay? If it's an early complement disorder, they're going to get pyogenic infections. If it's late complement, they're going to get recurrent Neisseria meningitis, okay? And that's one of the favorite things on the boards. They love to ask this. Patient with second episode of Neisseria meningitis, what do you think about? Terminal complement disorder, okay? All right, so let's talk about the individual complement disorders, and we'll start off with the B cell defects. So primary B cell immunodeficiencies, some examples include X-linked agammaglobulinemia or Bruton's agammaglobulinemia, common variable immunodeficiency or CVID, specific antibody deficiency, hyper IgM syndrome, X-linked lymphoproliferative syndrome or Duncan syndrome, and then finally, transient hypogammaglobulinemia of infancy. Okay. So what type of infections do these patients with B cell defects get? What do they get? Sinopulmonary infections, right? We just talked about that, right? So they're susceptible to encapsulated organisms, strep pneumonia, H. influenza, Staph aureus. Why? Because there's no IgG and there's no IgM. They get viral infections like enterovirus, right? Viruses that attack the mucosal surface. Why? Because there's no IgA. They get protozoan infections of Giardia. Again, no IgA, no IgE, okay? All right. So X-linked agammaglobulinemia or Bruton's agammaglobulinemia is due to a mutation in something called Bruton's tyrosine kinase. And what happens is B cells are stuck in an immature stage called the pre-B cell stage. And because they're stuck, they can't mature into regular B cells, and because of that, they can't produce antibodies. Okay, and so this is located on chromosome XQ22. So it's X-linked. So you see it in boys. Okay, so your vignette's going to say a boy with sinopulmonary infections. Okay, these patients again are susceptible to encapsulated organisms. So have sinopulmonary infections. They'll be susceptible to enteroviral infections, including Giardia, recurrent ear infections, sinusitis, pneumonia. Okay, those are the three big words that you hear. Think about B-cell defects, think about X-linked agammaglobulinemia. But they also get meningitis, they also get sepsis, and they also get osteomyelitis as well too. Okay. So how do you make the diagnosis of X-linked agammaglobulinemia? Well, you look at flow cytometry, right? And remember, we're looking at name tags. So if you've got no mature B cells, what's the CD marker for B cells? CD19 and CD20. So you just run them through the flow cytometry, which kind of looks at their name tag. And if they don't have CD19 and CD20, therefore they've got X-linked agammaglobulinemia. So they've got no mature B cells. You won't find any antibodies when you check for IgG, IgA, or IgM. And they've got, of course, no antibody function because there's no antibodies to begin with. So what do you do for these patients? Well, you give them what they're missing. They don't have antibodies, so you give them exogenous antibodies. So you give them subcutaneous immunoglobulins or intravenous immunoglobulins. So what sub-Q or IVIG is, it's a pool, all right, of antibodies from like tens of thousands of donors, and they separate it and they purify it, and they have, so you got IgG for these patients as replacement antibodies. Okay, you can also give them prophylactic antibiotics as well too, because you know that the immune system is so sophisticated that even though you're giving other people's antibodies, it's never going to be as good as the patient's own antibody. So that's why some of these patients may also need supplementation with prophylactic antibiotics in addition to the IVIG or sub-Q IG. Common variable immunodeficiency. So there's or CVID, there's sort of a bimodal distribution of these patients in terms of when they present. The first kind of peak occurs at the 5 to 10-year-old age range, and the second peak occurs in their 20s and 30s, but you can have a lot of patients present much later on, okay? Now what happens in CVID is that you've got mature B cells, but they're not able to differentiate into plasma cells to produce antibodies, okay? So when you check flow cytometry, the CD19, CD20 is going to be there, so you can see that they have B cells, but when you check IgG and IgM, for example, it's going to be low, okay? Because they can't differentiate appropriately into plasma cells to produce antibodies. So what's going to happen is they're going to have poor antibody response because their antibodies are going to be low and suppressed. So they're going to get similar infections like the X-linked agammaglobulinemia, however. They'll get recurrent sinopulmonary infections with encapsulated organism. Again, those organisms, strep pneumo, H. influenza, okay? Staph aureus, Moraxella catarrhatus. A lot of times it can cause bronchiectasis or changes within the lungs because of chronic infection. And they'll also be susceptible to enterovirus and Giardia as well too. Now the interesting thing about CVID is they also get kind of an autoimmune disease. And so you might be thinking, well, that's kind of strange. We're talking about primary immunodeficiency, right? Meaning that the immune system is suppressed. Autoimmunity is when the immune system is overactive. How can you have both, right? So the answer to that is because you've got a dysregulated immune system, okay? You've got an immune system that's not functioning correctly. You've got lower antibody levels. It's not fighting infections as it should. You have this chronic inflammation that's going on, and that drives the autoimmunity, okay? So what happens in CVID is that these patients have a sarcoid-like disease where they actually have non-caseating granulomas in the spleen, the liver, and sometimes in the skin. They can also get a sprue-like illness that causes diarrhea, malabsorption, statorrhea, and protein-losing enteropathy. Unfortunately, a gluten-free diet doesn't really help. They have increased risk of other autoimmune diseases like autoimmune cytopenias and also thyroid disease. and they also have an increased risk of lymphomas as well too. Okay, so the clinical presentation is going to be a little bit different than your Bruton's gamma-globulinemia, and the age of presentation is going to be a little bit different, right? Your Bruton's is going to present much earlier. They're going to present probably like within the first year of life, okay? Your CVID is going to present later on in life, 5 to 10. Sometimes I've diagnosed it in adults as old as like 60 years old, okay? So how do you make the diagnosis of CVID? Well, again, you look for flow cytometry. Do you have B cells present? Now, remember, in Bruton's or XLA, you don't have B cells, but in CVID, you do have B cells. However, you've got low antibody levels, okay, and you're going to have poor antibody function, okay? So what does that mean when I say poor antibody function? How do you assess antibody function? So what we do is we actually vaccinate the child, okay? So we get a baseline titers for pneumococcal titers, for example, right? And we vaccinate them, and we see what the response is. If they respond to the vaccine, that means their antibody function is good. If they don't, that means their antibody function is poor. So we vaccinate them, repeat the test in about 4 to 6 weeks, look at their antibody response, streptococcal titer response. Okay, that's what I mean by antibody function. Now with CVID, you can't make the diagnosis in children less than 5 years of age because there's something that I'll talk about a little later called transient hypogammaglobulinemia of infancy, where they have kind of low immunoglobulin levels, but as they get older, it kind of resolves on its own. So that's why you can't make the diagnosis earlier than 5 years of age for CVID, okay? What's the treatment for CVID? The same as XLA, okay? You want to give them exogenous antibodies. They get IVIG or sub-Q IG. All right, what about specific antibody deficiency? So here's another contrast in the whole B-cell defect schema. So these patients have normal B cells, they've got normal antibody levels, but they've got poor antibody response, okay? So that differentiates it from XLA and also CVID. They get kind of similar infections, but maybe to a milder degree. They still get, recurrent sinopulmonary infections with encapsulated organisms. All right. Again, that diagnosis, flow cytometry, you've got B cells present, you've got normal IgG, IgM levels, but you've got poor antibody function for whatever reason. Okay? And the treatment, like the other two, IVIG and sub-Q IG. Right. Now, there's something called X-linked hyper-IgM syndrome. And what this is, it's an inability of B cells to class switch. Remember I told you before, IgM is the first antibody that's produced, okay? Then afterwards, you've got, interaction between T cells and B cells that allow that B cell to switch from the initial IgM to IgG. What happens in X-linked hyper-IgM syndrome is that these B cells are stuck producing IgM and they can't class switch to IgG, okay? Another problem is that there's an inability of T cells to interact with macrophages because of something called a CD40 ligand defect. And this CD40 ligand, not only is it important in T to B cell signaling to cause that class switch, it's also important for T cell to macrophage signaling as well too. So these patients are, one, not only susceptible to sinopulmonary infections, but they're also susceptible to opportunistic infections like PJP, okay? So they'll have both of those things because of this inability to class switch. So what you'll find is that they'll have normal or high levels of IgM, but low or absent levels of IgG and IgA. So on the screen there, you'll see CD40 ligand, and that's going to be missing or defective in patients with X-linked hyper-IgM syndrome. You don't have this interaction between T cells and B cells, so B cells can't class switch. They're stuck producing IgM and can't produce IgG. So how do you make the diagnosis? You do flow cytometry, looking for that CD40 ligand. It's not there. You've made your diagnosis of X-linked hyper-IgM syndrome. What do you do for these patients? They often require bone marrow transplantation because of that risk of PJP infection, opportunistic infections. In the meantime, you give them support with IVIG or sub-QIG and SOFAs for PJP prophylaxis. Now, there's something called X-linked lymphoproliferative syndrome. Now, what happens in this condition is that these patients have overwhelming near-fatal infections with Epstein-Barr virus. Okay, they get fulminant hepatitis, they can get bone marrow failure, and a lot of times, unfortunately, it progresses to lymphoma because the EBV virus triggers a polyclonal expansion of B cells. The defect mutation is something called SH2D1A gene. All right, so lastly we have in our B cell defect category something called transient hypogammaglobulinemia of infancy, right? This is a diagnosis of exclusion. We consider this a normal variant or an abnormal prolongation of the physiological nadir, right? Remember I told you before, initially when the baby comes out, has very high levels of IgG, the IgG is consumed, and eventually after 4 or 5 half-lives, you reach that nadir, roughly 4 to 6 months of age, right? And at that time, then the baby's immune system starts producing its own IgG. With this condition, we think these babies are kind of slow to mature their immune system, right? So they don't produce their IgG until later on, so you've got this kind of low, prolonged IgG, okay? Usually what happens, though, is that these kids will have low IgG normals, but when they're exposed to the infection, they mount an adequate immune response, okay? And usually the IgG will normalize by about 5 years of age. And that's the reason why you can't diagnose common variable immunodeficiency until after 5 years of age, because you don't know if it's just only transient hypogammaglobulinemia of infancy, okay? That will resolve after 5 years of age. All right. So we talked a lot about all these different B-cell defects, and I know it can get really confusing because they all present with sinopulmonary infections. How do you distinguish between one versus another? So I created this table to kind of look at, right? If anything, this is sort of the money shot, right, of how you distinguish between, right? So let's say you're given a clinical vignette and the child has, recurrent sinopulmonary infections. Which one of these is the correct one, all right? So the first thing you want to ask yourself all the time is you want to ask yourself, are there B cells present, okay? With XLA, you're not going to have B cells present, right? Remember that blockage in development is at the pre-B cell stage. So you're not going to have any mature B cells, okay? And because of that, you're not going to have any antibodies. You're not going to have any antibody response. Treatment, IVIG, sub-QIG. With CVID, you're going to have B cells present, okay? But those B cells can't differentiate properly into plasma cells, and so you're going to have low levels of antibodies. You're going to have an impaired antibody response. Treatment, again, IVIG, sub-QIG. With specific antibody deficiency, you're going to have normal B cell levels, you're going to have normal antibody levels, but you're going to have poor antibody response, okay? Treatment's the same, IVIG, sub-QIG. Hyper-IgM syndrome, you're going to have normal B cell levels, but that B cell can only produce IgM, not IgG, not IgA, and so you're going to have inappropriate antibody response. And because of the problems with fighting off opportunistic infections like PJP, you're going to need bone marrow transplantation in addition to IVIG, sub-QIG. And then lastly, transient hypogammaglobulinemia of infancy is the diagnosis of exclusion. You're going to have B cells present, you're going to have low antibody levels, but they can respond pretty well, pretty adequately. It's just they're kind of slow in developing their IgG levels, and treatment is just observation, and that's it. All right, so that's the crux of B-cell defects. Now we're going to move on, all right, to T-cell defects. Okay. So there's not that many isolated primary T-cell immunodeficiency. Why? It's because In order for B cells to function, you have to have T cell interaction. So a lot of times, if you've got a problem with T cells, it's going to be more of a global issue where you have combined defects. Okay, so if you want to think about kind of your examples of just isolated T cell defects, think about like DiGeorge syndrome, okay, and think about Nezelov syndrome, which is a thymic disorder. So what do patients with T cell defects get? They get problems with intracellular organisms and opportunistic infection, right? Remember that acquired T cell defect is like HIV is your prototypical type. You can get problems with mycobacterium, MTB, problem with herpes virus, family of viruses, CMV, EBV, varicella, okay, those types of things. Fungal infections, Cryptococcus, Candida, Aspergilli, Cocci, protozoan infections, PJP, toxo, and isosporiasis. Okay. All right, now DiGeorge syndrome. What happens in DiGeorge syndrome that causes the immune system to go awry? Now, if you want to look back, way back in your medical school days in your embryology class, right? DiGeorge syndrome, it results from the failure of the third and fourth branchial arches. All right. So what's responsible? What's the result of those third and fourth branchial arches, right? You've got your thymus there, you've got your parathyroids, right? So if you don't have your thymus there, that's going to be a huge problem. That's where T cells are educated. That's why you're going to have a T cell defect in these patients with DiGeorge syndrome, right? You're going to have problems with calcium metabolism and regulation if you don't have your parathyroids, okay? That's why a lot of these patients will present with seizures because of calcium issues, because they don't have their parathyroids. There's also migrational problems, so they'll have heart, face problems as well, abnormalities as well too. So the chromosome is 22q11, as you all know. They present with varying degrees of immunodeficiency, hypocalcemia because of the lack of the parathyroid gland, congenital heart disease, your tetralogy of Fallot, your overriding aortic arch, transpositions. Those are the types of things that they're going to have. They're also going to have facial abnormalities, cleft lip, cleft palate. In complete DiGeorge, you're going to have both deficiency in both T cells and B cells. And in the intermediate, you also have like partial DiGeorge, which is more just like T cell defects. All right. So this is a nice mnemonic to remember, catch-22 for DiGeorge syndrome. So you can think about cardiac issues, abnormal facies, A, T for thymic hypoplasia or aplasia, cleft lip, cleft palate, hypocalcemia, and on chromosome 22. Yep. All right, so let's move on to combined T and B cell defects. So I'm going to talk about SCID, or severe combined immunodeficiency, Wiskott-Aldrich syndrome, ataxia telangiectasia, Bloom syndrome, and the Megan breakage syndrome. So let's start off with SCID, or severe combined immunodeficiency. All right, so there's a host of genetic defects that cause SCID, okay? IL-2 receptor gamma defect is the most common. It's in boys. We just got one recently in our institution. There's a whole bunch of other ones, but I'll talk about IL-2 receptor defect and ADA deficiency because those are the most common, okay? So what happens with SCID? They usually present in the first few months of life, and they're very, very sick, okay? They've got eczematous skin lesions, they've got chronic lung infection, chronic diarrhea, failure to thrive, lymphopenia. They'll present with septicemia. This is really a medical emergency. So these patients need to go to immunology as quick as possible so they can get bone marrow transplantation as quick as possible, okay? Studies show that they need to be transplanted by 3.5 months of age, where their 5-year survival rate is going to be about 90%. If you pass that mark, their 5-year survival is only about 50%. So a huge drop if they get past that age and they start having infections, right? So you want to catch them before they start having infections. It's important to kind of recognize the sick babies that you think have SCID. It is a medical emergency, okay? So we already know what they get. They pretty much get everything under the sun, okay? All types of infections, fungal infections, opportunistic infections, they're pretty sick. So one of the most common ones, or the most common one, is your X-linked SCID, also known as your IL-2 receptor gamma defect. This occurs in about 50% of babies that present with SCID, right? So if you phenotype them, meaning that you look to see if they have T cells, B cells, or NK cells, you'll see that for this particular group of X-linked SCID, they'll have no T cells present, okay? They'll have B cells present, but they'll have no NK cells or natural killer cells present. Doesn't mean that they work, just means that they're present when you do flow cytometry, kind of looking for them, right? The mutation is in the common gamma chain, and why this is so important is because it's used by several receptors, IL-2, IL-4, IL-7, right? Remember I told you before that interleukins or ILs are like the language of the immune system, right? So if you have these problems in communicating, you don't have IL-2, IL-4, and IL-7, that's a huge problem for the immune system, and that's why these patients are so sick, okay? How do you make the diagnosis? It's with molecular analysis and with bone marrow transplantation. Now, I didn't specifically cover it in this talk because not all states are doing it, and what I'm talking about is the newborn screen, all right? I don't know if what state each of you guys are from, but a lot of states now, I guess the majority of states now are doing the newborn screen for SCID now. So we're able to kind of detect these infants earlier on, and what it does is it basically looks for something called TREX, which is kind of your surrogate for T cells, and so we can detect these babies quicker. But I didn't put it on here because I don't think the board is going to have that on there because not all states are doing it right now. But eventually that's something that all states I think will have is the newborn screen for SCID. In any case, the way you diagnose X-linked SCID is through molecular analysis. You look for that genetic defect, and the treatment is bone marrow transplantation as quick as you can. All right. Adenosine deaminase deficiency, or ADA deficiency, this occurs in about 15 to 20% of all cases of SCID. If you look at the phenotype, there's going to be no T cells, no B cells, and no natural killer cells on flow cytometry, okay? This is an autosomal recessive condition. What happens is ADA, or adenosine deaminase, catalyzes the deamination of adenosine into inosine. So without it, what happens is you have a lot of toxic metabolites that build up. And these toxic metabolites kill off T cells, B cells, and NK cells. And that's why when you do flow cytometry, you can't find any T cells, B cells, or NK cells, okay? You can make the diagnosis by looking for ADA in your red blood cells. The treatment is either with bone marrow transplantation or gene therapy, where you actually inject the missing gene and have the host's own cells produce adenosine deaminase. Wiskott-Aldrich syndrome. So a nice mnemonic for Wiskott-Aldrich syndrome is something called EXIT, right? So these patients get eczema, right? It's X-linked, so you'll see it in boys. They'll have immunodeficiency, they'll have thrombocytopenia. The mutated gene is on something called WASP on the X chromosome, P1122. And if you look on the peripheral smear, you'll see small platelets. So this is really the only condition where you have thrombocytopenia and yet see small platelets on the peripheral smear. So that should be a red flag to you that whenever you see something on your vignette or in clinical practice, if a patient has thrombocytopenia but has small platelets on the peripheral smear, think about Wiskott-Aldrich syndrome, right? Because if they have like ITP, for example, they've got thrombocytopenia, but when you look on the peripheral smear, you're going to have large platelets, right? You're going to have megakaryocytes, right? So this is the opposite. So it really clues you in to the diagnosis of Wiskott-Aldrich syndrome. So the treatment is bone marrow transplantation while they're waiting to get IVIG and prophylactic antibiotics. Now, ataxia telangiectasia, what do these patients get? Well, don't you wish all of your questions would be like this, right? Yeah, they get ataxia, and telangiectasia. All right, so there's a progression. They get ataxia early on, and they get telangiectasia, and then later on they get immunodeficiency. But not all symptoms occur all at once, and they don't always occur later on, okay? This is an autosomal recessive condition. It's caused by a defect in something called the ATM gene that's responsible for DNA repair, okay? So when you can't repair DNA, guess what happens? You get cancer, right? Because you damage your DNA, you can't repair it, you get cancer. So these patients have a high risk of getting lymphomas and leukemias from ionizing radiation. So how do you make the diagnosis? Well, pretty straightforward. Ataxia, telangiectasia, and finally, something that's really unique is they get elevated alpha-fetoprotein, okay? So there's really no pediatric condition that causes an elevated alpha-fetoprotein. So whenever you see an elevated alpha-fetoprotein, think about ataxia telangiectasia. In adults, they get hepatocellular carcinoma of the liver, and yeah, they get elevated alpha-fetoprotein, but we're talking about pediatrics here. So if you got those things together, that's ataxia telangiectasia. Now, Bloom syndrome is also a chromosome instability disorder. It's a defect in a DNA repair gene called DNA ligase. It's autosomal recessive. They get kind of clinical manifestations of small stature, telangiectasias, CNS abnormalities, and also immunodeficiency. And of course, there's a high association with lymphomas and leukemias because you're not able to repair DNA defects. Now, Megan-Breakage syndrome is also a chromosome instability disorder, and it's caused by the NBS1 mutation, which produces nibrin, and again, it's responsible for repair of double-stranded DNA breaks. It's also autosomal recessive. Clinically, these patients have kind of like a bird-like facies, microcephaly, normal or near normal IQ, and also immunodeficiency. And of course, they're susceptible to lymphomas and leukemias because they can't repair DNA. All right, so now we're going to move on to phagocyte disorders. Okay, so I'm going to talk about your different types of congenital neutropenias. We'll talk about chemotaxis disorders, and then finally we'll go over some of the killing defects. Okay? So first, let's start with your neutropenias. So your congenital neutropenia includes your Kostman syndrome, right? This is autosomal recessive, and it's due to a mutation in your HAX1 gene. So these infants present with opportunistic infections and overwhelming infections due to the neutropenia. There's also something called severe chronic neutropenia, which is autosomal dominant, and it's due to a mutation in your neutrophil elastase. And then finally, there's something called cyclical neutropenia, where it's not constant, it cycles, right? Every 3 to 6 weeks, you have this nadir in your neutrophil levels. And when that happens, these patients are susceptible to opportunistic infections. The mutation is also in neutrophil elastase. And the kind of interesting thing is, although 2 patients may have the exact same genetic defect, one may have chronic neutropenia and the other may have cyclic neutropenia. Why that's so, we don't really know, but that does happen. Okay. Phagocyte chemotaxis disorder, there's 2 ones that the boards love, especially the type 1, which is leukocyte adhesion defect. It is exceedingly rare. Extremely rare, but the board loves this question. So they'll ask you, there's a baby with delayed separation of the umbilical cord, has omphalitis, what should you think about? And the answer should always be leukocyte adhesion defect, okay? So these kids have all those things that I mentioned before, but they also have severe leukocytosis, sometimes in the hundreds of thousands, okay? And what happens in this is the leukocytes are produced, but they're not able to go where the site of infection is because of this leukocyte adhesion defect. So you've got this overwhelming infection, and the leukocytes can't go to where they want to go to. What does the bone marrow do? It thinks, well, I'm just going to produce more. So it keeps on cranking out more leukocytes, up to the 100,000s of leukocytes, okay? But they can't get to where it needs to go, so you have these sterile abscesses at the site of infection, and you've got this pronounced WBC count, okay? And so anytime you hear those buzzwords, delayed separation umbilical cord, omphalitis, gingivitis, think about leukocyte adhesion defects, okay? Now there's a type 2 where you get a defect in the fucosylation of your Sal-Lewis moiety. These patients have kind of other features, but similar to LAD. The leukocytes can't go to where they need to go to, but the type 2s have intellectual disability, they've got poor growth and abnormal facies, and they've also got this sort of Bombay blood type. Phagocyte killing defects include Job syndrome or hyper IgE syndrome, Shidik Higashi, chronic granulomatous disease, and specific granule deficiency, and I'll go over each one of those. First, Job syndrome. It's also known as hyper IgE syndrome. Okay, now it's kind of a misnomer because the IgE is usually elevated, but it's not required, and sometimes it's not that elevated, especially as the child grows up, the IgE actually normalizes, and also you've got a host of other conditions that have very high IgEs, atopic dermatitis being one of them, right? You can get atopic dermatitis, I've seen them in the 30,000s with just regular atopic dermatitis. So be careful, it doesn't have to have elevated IgE in order to make the diagnosis of Job syndrome. What they will have, however, is that they're going to get recurrent boils or abscesses, okay? That's important. They've got this severe eczema, okay? They've got some other features that are interesting, such as they've got delayed eruption of primary teeth, okay? So if you get dental x-rays, there's actually 2 sets of teeth because the first set doesn't erupt out. They've got chronic lung infection, so they'll develop pneumatocysts. They've also got some bone issues, such as scoliosis, hyperextensibility, osteoporosis as well, too. They've got kind of like distinguished facial features, these like coarse faces, asymmetrical face, broad nose, prominent forehead, and triangular jaw. And I already mentioned the osteoporosis and risk for pathological fractures with these patients. Shidik Higashi is caused by impaired lysosome degranulation. It is an autosomal recessive disease. These patients will have cutaneous and also sinopulmonary infections. They'll have partial oculocutaneous albinism, okay? And why is that? Well, the reason being is like your melanocytes are actually formed in these lysosomes. So when you have this lysosome defect, you don't have melanocytes, and that's why you get the oculocutaneous albinism in addition to the other immunodeficiencies as well. They will also have intellectual disability and progressive peripheral neuropathy. Treatment is with bone marrow transplantation. Unfortunately, that kind of helps with the immunodeficiency, but it doesn't cure the progressive peripheral neuropathy. And unfortunately, a lot of kids, they end up in a wheelchair by the time they're adults. Now, specifically, what you're looking for is the peripheral smear. The peripheral smear is going to show you giant granules, and that's kind of pathognomonic for Shidik Higashi, okay? Giant granules. Chronic granulomatous disease. So the most common type is the X-linked type, right? It counts for about, I would say about 70% of all cases of chronic granulomatous disease. And what happens in CJD, or chronic granulomatous disease, is that these patients aren't able to generate the respiratory burst to kill off organisms, especially catalase-positive organisms. So they're going to be susceptible to things like Staph aureus, Serratia, Burkholderia, Aspergillus, Chromobacterium, Nocardia. Anytime you see this list of organisms growing out in the blood, think about chronic granulomatous disease, all right? And because they're not able to kill off the organism, what happens is the macrophages form granulomas, and that's hence why it's called chronic granulomas. So they form these big granulomas. So a lot of times these patients can get GI obstruction from these granulomas. They can get urinary tract obstruction because of these large granulomas. So how do you make the diagnosis? We do something called the DHR, or dihydrorhodamine oxidation test, and basically you're looking for that oxidative burst. Before we used to do something called the NBT test, but that was very subjective and not very objective, so that's been largely replaced by the dihydrorhodamine test to look for granulomatous disease and look for that respiratory burst. What do you do for these patients? Well, you give them prophylactic antibiotics that cover for the organisms that I mentioned, the Bactrim for like Staph aureus, itraconazole for your fungal infections. Interferon gamma is of good use. What it does, it actually supercharges your macrophages so that they're able to kill off the catalase positive organisms. Okay, so those are the three things that really help patients with chronic granulomatous disease. There's something called specific granule deficiency, and basically these patients lack primary and secondary granules, and they can't fuse together to form the phagosome to kill off pathogens. All right, so last arm of the immune system that we're going to talk about is your complement deficiency. Okay, so there's early complement deficiency, and there's also terminal complement deficiency. If you have early complement deficiency, i.e., your C2 to C4 complement disorders, these patients are going to present with pyogenic infections, and they also are at increased risk of autoimmune disease. So again, you might ask, well, how can they have autoimmune disease? What does complement have to do with autoimmune disease? Well, it turns out complement has a huge role in clearing up immune complexes. Okay? So without complement being able to clear your immune complexes, your immune complexes start to deposit in certain organs, and that's why you get the autoimmune disease. So these patients are at risk of lupus because of that deficiency of the complement system to clear immune complexes. Now, for terminal complement deficiency, these patients get recurrent bacterial infections with Neisseria meningitis and Neisseria gonorrhea. Okay, how do you make the diagnosis? Well, you do something called the CH50. All right, you screen, and if that's undetectable or low, then you check for the individual complement factors. If you think it's an early complement, C2, C3, C4. Late complement, then you check C5, C6, C7, and C8 and C9. Okay, treatment is with prophylactic antibiotics, and you vaccinate them for the things that they're at risk for. So like meningococcus vaccine or pneumococcal vaccine or H flu vaccine. All right, so this is kind of a table that kind of summarizes different defects, okay? And what are some things that you should think about, and how should you approach someone with a suspected immunodeficiency, right? So remember at the beginning I told you, when you're presented with a patient or a vignette or a clinical scenario, you want to think about, right, what arm of the immune system are we looking at? What arm of the immune system is this patient having problems with, okay? Is it a B cell defect? Is it a T cell defect? Is it combined? Is it phagocytes? Is it complement? Right? That's the way you're going to be able to approach this, right? So just a quick rundown. Remember B cells, sinopulmonary infections, okay? Encapsulated organisms. T cell defects, isolated T cell defects, right? It's going to be your opportunistic infections, intracellular infections. Combined, it's going to be everything. Sinopulmonary, intracellular, opportunistic infections. Phagocyte disorders is going to be like organ abscesses. Think about those types of things, okay? Complement, you want to think about, pyogenic infections if it's early, Neisseria meningitis if it's late terminal complement defect, all right? And so then how do you, within that sort of arm, do you get to the specific diagnosis? Well, if you want to think about B cell, if you suspect B cell defects, right, there's XLA, there's CVID, there's specific antibody deficiency. How do you differentiate between all of those? Well, you want to think about, well, where's the problem, okay? You want to do a quantitative evaluation and a qualitative evaluation. You want to say, are the things that are necessary there. Number one, that's quantitative. And two, you want to ask yourself, are they actually working? Okay? So with B-cell defects, you want to do flow cytometry. You want to see, are there B cells? Okay? If there's no B cells, then there's your answer. It's XLA. Okay? And then you want to look at, what about the antibodies? Are there antibodies present? Are they completely gone? Are they low? Are they normal? And then finally, you want to look at function or qualitative evaluation. Is the antibodies that are there actually working? Okay, so that's when I talked about, their antibody response. So is it present or is it not present? Okay. For your T-cell defects, again, you want to look at, it's kind of the same thing. Do you have your white cells there? Remember, with SCID, you're going to have lymphopenia, leukopenia. All right, so you're going to look for that, and then you're going to do an evaluation to see if those T cells are actually working or not working. Okay. Phagocyte defects, you're going to look for like LAD, leukocyte adhesion defect, for example. The presentation is going to be very important. They've got delayed separation of umbilical cords, gingivitis, umbilical. Do a CBC. If it's really sky high, then you want to think about leukocyte adhesion defect. If it's chronic granulomatous disease, you want to think about some of the pathogens that they're susceptible to, right? The strange one, Serratia, Chromobacterium, Burkholderia. All those things should make you think about chronic granulomatous disease and then do the dihydrorhodamine test to confirm. Okay? And then finally, complement defects. If you've got a scenario where a patient is having recurrent pyogenic infections and also has lupus, you want to think about early complement defects. Whereas if you have a patient who has recurrent Neisseria meningitis, then you want to think about terminal complement defects. Okay? All right. So what about vaccinations in your immunocompromised, right? So definitely live vaccines are a no-no. You don't want to give them things like BCG, OPV, MMR, varicella, live intranasal influenza, smallpox, and rotavirus. And actually, we've had a few cases of undiagnosed SCID who were given the rotavirus and they got really, really sick because of that. Fortunately, as I mentioned, with perhaps all of the states adopting the newborn screen for SCID, we won't have that in the future. All right, so let's go over some questions. All right, so we're going to start off with the first question. Get your question answering thing ready. All right, so the first question is, a 2-month-old boy is brought to your emergency department with respiratory distress, tachypnea, and hypoxia. The child is noted to have a dry, scaly rash, and it's less than 5 percentile for weight. Chest x-ray shows bilateral hazy infiltrates and an absent thymus. What is the best test to evaluate this patient's diagnosis? Is it A, CH50 with quantitative C3 and C4? Is it B, alpha-1 antitrypsin level? Is it C, quantitative IgG subtypes? Is it D, flow cytometry for T and B cells? Or is it E, flow cytometry for CD11 and CD18? All right, go ahead and answer that question. All right, great. So the majority of you answered it correctly. It is flow cytometry for T cells and B cells. What are we suspecting in this infant who presents with this in really bad shape? SCID, exactly. So what you want to know is what their phenotype is, right? You want to see, obviously they're going to have no T cells, and you want to see what their B cells are like. So the diagnosis you suspect is SCID. The appropriate evaluation is flow cytometry for T cells and B cells. Now, for those of you who answered E, flow cytometry for CD11 and CD18, that is for evaluating for leukocyte adhesion defect, right? So those patients are going to present differently, right? How are they going to present leukocyte adhesion defect? They're going to present with delayed separation of the umbilical cord. They're going to have severe gingivitis, umbilical, right? Those types of things. They're not going to present with like this kind of bilateral hazy infiltrates, which is suggestive of PCP, pneumonia, and hypoxia. Okay, and the severe eczema and the failure to thrive, that all points toward for SCID. And that was the answer. Okay, next question. A 4-year-old boy comes to your clinic with a history of eczema, multiple admissions for pneumonia, and easy bruising. What test can help you confirm the diagnosis? Is it A, dihydrorhodamine test? Is it B, small platelets on peripheral smear? Is it C, C1q inhibitor levels and function? Or is it D, diphtheria vaccine titers? Very good. So 87% got the right answer, small platelets on peripheral smear, right? You've got this kiddo with eczema, all right? You've got this pneumonia and easy bruising. So what do you think of? Wiskott-Aldrich syndrome, right? Remember, that exit mnemonic, right? Eczema, X-linked, it's a boy, immunodeficiency, T, thrombocytopenia, hence the easy bruising, okay? So let's look at the next answer, diphtheria vaccine titers. That's going to be more for evaluation of B-cell defects, right? So you're looking more for like, maybe X-linked agammaglobulinemia in a 4-year-old or whatnot. But those patients aren't going to have like easy bruising. They're not going to have eczema. So the right answer is Wiskott-Aldrich syndrome. And looking at the peripheral smear for small platelets, that's going to really help confirm your diagnosis. Okay. Third question. A 4-year-old boy comes to your clinic with a history of frequent falls, recurrent pneumonias with multiple admissions, and an elevated alpha-fetoprotein. What is the most likely diagnosis? Is it A, Wiskott-Aldrich Bombay variant? Is it B, ataxia telangiectasia? Is it C, leukocyte adhesion defect type 2? Or is it D, Duncan syndrome? All right, very good. The right answer is ataxia telangiectasia, history of frequent falls, right? They got recurrent pneumonias, elevated alpha-fetoprotein. I told you before, there's not really anything in pediatrics that causes elevated alpha-fetoprotein except for ataxia telangiectasia. That is the correct answer. Okay, next question, number 4. An 8-month-old boy comes to be evaluated for a history of recurrent otitis media and pneumonia. He has a family history of an uncle with a similar problem. Which of the following tests should be done next in the workup? Is it A, quantitative immunoglobulins? Is it B, flow cytometry for T cells? Is it C, the nitroblue tetrazolium test? Or is it D, chest x-ray to evaluate for the presence of a thymus? All right, very good. You guys are batting like 100%. Awesome. So that is the correct answer, quantitative immunoglobulins. You've got a family history of an uncle. Remember, XLA, recurrent infections, recurrent sinopulmonary infections. It's genetic. You've got an uncle with a similar problem. The test that you want to do is your quantitative immunoglobulins to look for absence of IgG. Great. Next question. A 4-month-old boy is admitted to the pediatric intensive care unit for PJP pneumonia. The patient is 75th percentile for height and weight. Initial immune workup shows absent IgG levels, absent IgA levels, and normal IgM levels. What is the most likely diagnosis? Is it A, severe combined immunodeficiency, common variable immunodeficiency, specific antibody deficiency, hyper IgM syndrome, and X-linked agammaglobulinemia? Very good. Hyper IgM syndrome, that is the correct answer, right? So these patients are going to be a little bit different from your SCID patients. They're not quite as sick. He's not failure to thrive. He's on 75th percentile, but he's susceptible at risk or gets PJP infections. You've got normal IgM levels, but absent IgA levels. Remember, hyper IgM syndrome, you don't have to have elevated IgM. They could be normal, but it's really the inability for B cells to class switch to other immunoglobulins like IgG, and that's the problem. So that is the correct answer. By the way, all these are actual cases that I've seen. So I've written the questions for actual cases that I've seen over time. So this was actually a kiddo that I saw like 15 years ago. Okay. All right. So now I'm going to talk about allergic reactions, right? This is going to be a lot of bread and butter stuff that you deal with on a day-to-day basis. So the first thing is we should categorize or classify the different types of allergic reactions, right? So if you look at the Jelen-Coombs classification, there's type 1 through type 4 classification. I added on a type 5 because there's a different classification there, but the traditional is a Jelen-Coombs type 1 through 4. So if you look at type 1, it's considered an immediate hypersensitivity reaction. It's IgE mediated, okay? Your type 2 is your cytotoxic reaction. It's IgM or IgG mediated. Your type 3 is your immune complex or antibody-antigen complex mediated reaction. Your type 4 or your delayed reaction is your T cell mediated. And then finally there's that type 5, which is kind of a little bit different than the 1 through 4. It's an autoimmune stimulatory reaction where there's actually a stimulatory effect of the autoimmune IgG antibody on the receptor. Okay, so we'll go over each one of these. And similar to the immunology part, when you have an allergic reaction, you want to think about which type is it. Is it 1, 2, 3, or 4? And that'll kind of give you an idea of what to expect. Okay. So first let's start with the type 1. This is the kind of the classic allergies reaction, right? These patients get hives, allergic rhinitis, asthma, food allergies, latex allergies. They're all IgE mediated, okay? There's an acute phase and there's a late phase. So with the acute phase, this occurs within minutes to 1 hour after exposure, okay? What happens is the antigen, let's say for sake of argument, it's a food allergy. The peanut antigen binds to preformed Ig antibodies. Then that Ig binds to receptors on mast cells. The mast cells degranulate all of their components and things, which include histamines, leukotrienes, prostaglandins, and cytokines, and that's why you have all the symptoms that you have. Remember the urticaria, the angioedema, the bronchospasm, all that stuff. Remember H1 or histamine receptors cause that wheal and flare responsible for the urticaria. It causes the bronchoconstriction, it causes the pruritus, whereas H2 causes increased gastric acid secretion. Okay? Your late phase can occur 3 to 12 hours later. So what happens is you have your initial degranulation by mast cells, right? And in addition to those things that I mentioned, they also release cytokines, which call other cells to come to the area, right? So they can call on other cells such as eosinophils and basophils, and then those are responsible for the late phase reaction. The probability of having a late phase reaction depends on the severity of the acute phase reaction, right? It kind of makes sense. If you have a huge acute phase reaction, you've got all these cytokines, which again are the language of immune cells, and you recruit a whole bunch of eosinophils and basophils, you're going to have a much larger late phase reaction. Okay. So now before we get on to type 2, just the key thing to remember is your type 1 reaction is going to occur within a few minutes to at most a few hours after the triggering event. Okay. So if your patient or in the clinical vignette you have a parent saying, "Oh, my child got a rash," and they ate peanuts the day before, that's not going to be because of a food allergy, right? If it's a food allergy and IgE mediated, it's going to occur immediately, within minutes to hours. So with all these, remember, the time frame is extremely important in trying to figure out what type of reaction it is, okay? And same thing for antibiotics, right? Parents a lot of times tell us, oh, he got amoxicillin yesterday, developed a rash today. That's not a type 1 immediate reaction. That's a different reaction. It may not have anything to do with the amoxicillin. Okay? Now, your type 2 reactions or cytotoxic reaction occurs when you have IgM or IgG antibodies that bind to either fixed tissue or cell receptors. Okay? The binding of the antibody causes target cell destruction via complement activation, opsonation from the cells, or phagocytes that attack the antibody-coated cells. Okay. So these are some examples of fixed tissue antigen diseases. So, for example, in Goodpasture's disease, you've got antibodies, okay, that attack the basement membrane of in your pulmonary cell or in your kidneys, and that's how you get Goodpasture's. If you have antibodies that attack the acetylcholine receptor on muscle cells, then you get myasthenia gravis. Right? You can also have the same thing with target cell receptors. Okay, so if you have antibodies to platelets, you get autoimmune thrombocytopenia. If you have antibodies to red blood cells, you get autoimmune hemolytic anemia, and the same with autoimmune leukopenia when you have antibodies to leukocytes. Type 3 hypersensitive reactions are immune complex. So you want to think about vasculitis whenever we talk about immune complexes, right? Immune complexes form when you have antibodies that bind with antigen. And when these antibodies and antigen form these immune complexes, and there is a slight antigen excess, the immune complexes start to deposit where they're not supposed to deposit. Okay, so if they start depositing in small vessels, you get a vasculitis. Okay, and when this happens, it activates complement. You have an inflammatory cascade. It causes necrosis of the small blood vessels, and hence you have leukoclastic vasculitis. You can also have these immune complexes deposit in glomeruli, right? So you get glomerulonephritis, for example, in lupus glomerulonephritis. You can get it in the skin, so you get leukoclastic vasculitis, okay? And this causes this hemorrhagic indurated skin lesions that you see. So 2 examples of type 3 immune complex reactions are serum sickness and also your Arthus reaction. The differences between the two is one systemic, the other is local. So in serum sickness, you have a systemic reaction. You have a large amount of antigen is injected into a non-immunized animal, and about 1 to 3 weeks later, you get this systemic reaction with serum sickness. In the Arthus reaction, this is a localized reaction. You have a hyperimmunized animal, it's given an injection of antigen, you have a lot of circulating IgG antibodies already there, and so these immune complexes form, you get a large local reaction, the Arthus reaction. In your type 4 or delayed reaction, this occurs 24 to 72 hours later, okay? So you have previously sensitized T cells that interact with the antigen. So examples of this include contact dermatitis and tuberculin sensitivity, right? So does everyone ever wonder why you get that induration if someone's been exposed to tuberculosis in the past? What actually happens? So I'll kind of go over the steps, and this will be an example of a delayed type 4 hypersensitivity reaction. So if you've been exposed to tuberculosis in the past, what happens is your T cells have seen it already, okay? When you're exposed again, when you give somebody the PPD test, all right, you're basically injecting that antigen into their skin. Antigen-presenting cells then go to that area, gobble it up, all right, then travel to the local lymph nodes and present it to your T cells, okay? If your T cells have seen tuberculosis before, it will interact with the antigen-presenting cell. And when it does that, it'll then recruit other cells to the area, and that's why you get that induration that you see in a PPD test, 48 hours to 72 hours later. So that's a very typical example of a type 4 delayed reaction, and that's how we can screen for people who have already been exposed to tuberculosis. If you haven't been exposed to tuberculosis, when that antigen cell picks up that PPD antigen, then goes to local lymph nodes, the T cell hasn't been exposed to it, it's not going to create that immune response. The next time, however, if they have been exposed to it, then they'll get that immune response. But if they haven't, then they won't get a response. Does that make sense? Okay, that's why we do that. All right. Type 5 is an autoimmune stimulatory reaction where you have Ig autoantibodies that have a stimulatory effect on the receptor. So an example of this is Graves' disease, right? You've got IgG autoantibodies that can bind to the TSH receptor, and by doing that, it produces a stimulatory effect and you get hyperthyroidism. Anaphylaxis. So anaphylaxis is basically the ultimate Ig-mediated hypersensitivity reaction. It's like the severest form of reaction for Ig-mediated hypersensitivity reactions. So common causes that we all know about, antibiotic reactions, right? Penicillin, cephalosporins, foods, your peanuts, tree nuts, shellfish, eggs, latex allergy, anesthetic agents, and insect stings. Okay? Now, there's an old term, but I still use it here because you see it a lot in the literature still. It's called anaphylactoid, right? Really, the new term is non-Ig mediated anaphylaxis. And that is the appropriate term because you can't clinically distinguish between anaphylaxis and anaphylactoid reactions clinically. The only difference between the two is one is IgE mediated and the other is non-Ig mediated, okay? With the non-Ig mediated anaphylaxis, i.e. anaphylactoid reactions, you get direct mast cell degranulation. Whereas with Ig mediated, it's mediated through Ig, as the name implies. Okay? So examples of anaphylactoid reactions or non-Ig mediated anaphylaxis are your aspirin, NSAID reactions, your opioid reactions, radiocontrast reactions, and sulfite reactions. Both anaphylaxis and anaphylactoid occur within 5 to 30 minutes after antigen exposure, right? And that's consistent of what we talked about with your type 1 Ig-mediated reaction. It's immediate within minutes after antigen exposure. You've got multi-systemic symptoms, cutaneous, by far the most common, occurring more than 90% of the time. You get angioedema, urticaria, you get respiratory symptoms, wheezing, shortness of breath, throat tightness, cardiac hypotension, and you can also get GI symptoms like abdominal pain, nausea, and vomiting. Now, the one key thing that you should remember is this. You don't need hypotension in order to have anaphylaxis. A lot of people make this mistake and say, oh, well, the patient is only having wheezing and only having hives. That's not anaphylaxis. That's a huge mistake. That is anaphylaxis. You only need 2 organ systems to diagnose anaphylaxis, right? Hypotension is the last to go. You have all these counter-regulatory mechanisms in your body to prevent hypotension, right? If you think about it, hypotension is detrimental, right? You're having low blood flow to your brain. Your body will do everything it can to prevent hypotension. Hypotension is the last thing to go. So you don't need to have hypotension in order to categorize it as an anaphylactic reaction. You only need 2 organ systems. If someone tells you, I'm throwing up and I have hives, that's anaphylaxis. My throat's tight, I've got hives, that's anaphylaxis. I can't breathe, my stomach hurts, that's anaphylaxis. And you need to treat that patient early and immediately with epinephrine. Okay, so huge key point. I see it all the time. I see it in urgent care, emergency room, get a call for consultation. Patients having those things without hypotension, you got to give them epinephrine. Adrenaline right away. You can't wait. Okay. So the treatment, like I said, epi, epi, epi. All right. First line, studies show that fatalities from anaphylaxis occur when there's, 1, a failure to recognize anaphylaxis. Oh, the patient's not having hypotension yet, it's not anaphylaxis. No. That is anaphylaxis if you've got 2 organ system involvement, and you got to treat them early. If you don't treat them early, then that's a risk factor for fatal anaphylaxis. So those 2 key points, okay? So the dose is 0.01 milligrams per kilo of a 1 to 100 dilution intramuscularly in the anterior lateral thigh. What does epinephrine do? Okay, it has both alpha and beta adrenergic effects that counter-regulates all the things that anaphylaxis causes. So it causes, the epinephrine causes bronchial relaxation, causes vasoconstriction to counteract anaphylaxis, and also decreases vascular permeability as well too. What about patients on beta blockers? What do you do about those patients? So first of all, if a patient is at risk for anaphylaxis, you don't want to give them beta blockers, right? Because it interferes with the treatment, first-line treatment of anaphylaxis. However, if a patient is already on beta blockers and they're having anaphylaxis, epinephrine is still the first-line medication. Okay, you still give it to them because most of the time it'll still work. 90+% of the time it'll still work. In those rare cases where after giving the first administration it doesn't work, then you can try glucagon or vasopressin. These medications work via a different mechanism that doesn't involve the beta receptor. It works via cyclic AMP, and so you could try glucagon as an alternative if epinephrine doesn't work initially. But epinephrine is always the first-line medication. Don't let the boards trick you or anybody else trick you. Epinephrine is always first line for everybody, okay? Now, treatment is going to be your typical ABCDs, right? Airway, you can give albuterol if the patient's wheezing. If it's severe constriction, intubation may be needed. Circulation, volume resuscitation. Remember, anaphylaxis also causes increased vascular permeability, so there's a lot of third spacing that occurs. So for those patients, if you can't sustain their blood pressure, the way after giving epinephrine, the way to treat them is to give them large boluses of fluids. Okay, you got to replace the intravascular volume. All right. Drugs, again, epinephrine. I can't hark that enough. Always first line, first choice medication. Fail to recognize anaphylaxis and fail to give epinephrine promptly are the two major causes of fatalities. You can also give histamine, H1 and H2 blockers, but that's after giving epinephrine. And steroids may prevent the late phase reaction that we talked about earlier. What about radiocontrast mediated reactions? What do you do for those? Well, remember, this is a non-Ig mediated reaction that's caused by direct mast cell degranulation. Okay, there's a lot of urban myths out there. Oh, I've got a seafood allergy, I can't get radiocontrast. That's not true whatsoever. I've got an iodine allergy, I can't get radio. That's absolutely not true whatsoever. Okay, so don't fall into that trap. Okay, it has nothing. Seafood allergy, iodine allergy has nothing to do with radiocontrast reactions. Okay, what does have something to do with radiocontrast reaction are certain risk factors. Being of the female gender, having concomitant asthma, having a prior reaction, obviously, and also underlying cardiovascular disease. What do you do about it? Well, these days we give non-ionic or hypoosmolar radiocontrast. There's also a really effective pre-treatment regimen where you give prednisone 0.5 to 1 mg per kg, 13, 7, and 1 hour before they get the radiocontrast. You also give diphenhydramine 0.5 to 1 mg per kg 1 hour before their study. Okay. You can also give albuterol as needed and ranitidine as needed as well too. All right, urticaria. Urticaria, boy, we see so much urticaria. And you can kind of classify urticaria in acute versus chronic, right? Anything that lasts less than 6 weeks is considered acute urticaria. Anything that lasts more than 6 weeks is chronic urticaria. Now, urticaria can be Ig mediated. Again, we've got foods that can cause reactions, drugs, pollens, insect things. But remember, there's so many things that can cause urticaria. Stress can cause urticaria. Sunlight can cause urticaria. Any kind of skin irritation can cause urticaria. Viruses can cause urticaria. So a lot of things can cause urticaria. Okay? Now, chronic hives, by definition, is hives that are lasting more than 6 weeks in duration. 90% of the time, or more than 90% of the time, it's going to be idiopathic. Okay? It's
whatever's going on in their system, it's a skin condition, they get chronic hives, okay? Of the like 10% that we can identify a cause, think about thyroid disease, autoimmune disease, in adults more than children, malignancy, and also chronic infection. But those are typically pretty rare. Most of the vast majority of the cases is going to be idiopathic chronic urticaria. Now, there's interesting things called physical urticarias. For example, you have acquired cold urticaria. This is precipitated by cold exposure. So these patients, whenever they're exposed to cold, urticate and get hives. And actually, if they go swimming in cold water, they can actually have anaphylaxis in cold water. So you got to tell them not to go swimming in cold water. Be very, very careful. And the way to test this is with what's called a 5-minute ice cube challenge. Basically, you put an ice cube on their forearm, leave it there for 5 minutes, take it off, and during the rewarming stage, their skin will actually urticate for you right in front of your eye. So very interesting. The opposite of that is you have cholinergic urticaria. This occurs when patients urticate when it's hot or when they exercise, okay? They get these punctate hives that are very, very itchy. And then there's a host of other physical urticaria. You can have vibratory urticaria, vibration causes them to urticate, aquagenic water causes them to urticate. So a lot of different physical urticarias out there. The one thing that you always want to have to watch out for is urticarial vasculitis, okay? Because this is an autoimmune disease. Most of the other ones are benign. You can treat them symptomatically, but this one you have to watch out for. And what are those red flags that you want to watch out for? If the patient tells you that the lesion lasts more than 24 hours, that the lesions are not really itchy, but they burn and are tender, okay? If it leaves like residual markings, like ecchymosis, purpura, hyperpigmentation, those are kind of the sort of warning signs of urticarial vasculitis. And of course, if they have other constitutional symptoms, like they've got arthritis, fever, fatigue, and weight loss, that's a huge telltale sign that this is urticarial vasculitis. How do you make the diagnosis? Well, it's by skin biopsy, and then you can look at labs looking at like decreased C3 and C4 because there's active consumption of your complement factors, and also you can look at antibodies to C1q as well too to make the diagnosis of urticarial vasculitis. But really, it's a skin biopsy. Hereditary angioedema. So this is relatively rare, but you may see a few. It's due to a defect in something called C1q inhibitor. Okay, and there's two types. Type 1 is if you've got low levels of C1 inhibitor protein. Okay, type 2 is when you've got normal levels of C1 inhibitor protein, but it's not functioning. So either way, there's a functional problem of C1q. Okay, and these patients get recurrent episodes of angioedema, abdominal pain, and extremity swelling, and sometimes laryngoedema, which is the major cause of fatalities in these kids, right? They get something called erythema marginatum, which is kind of this serpentigious rash, right? They don't get urticaria. So if you have someone who has urticaria and angioedema, it's not hereditary angioedema. It's absolutely not, because these patients do not get urticaria, okay? The other caveat to take notice of is a lot of times these patients will have severe abdominal pain, and unfortunately, they'll have multiple surgeries, explanatory surgeries for this unexplained abdominal pain. So if you have this kid who comes in with this unexplained abdominal pain all the time, think about hereditary angioedema, because not only can you get swelling in the extremities and the lips and ears and stuff like that, you can get swelling in the GI tract, and that's responsible for the intense abdominal pain that these patients sometimes present with. And unfortunately, they get these unnecessary surgeries, okay? So how do you make the diagnosis? You can start off with screening C4 level. Because you have constant activation of complement, you have a low C4 level. And then after that, you can look for the C1 inhibitor level and also its function as well too, to kind of differentiate whether it's type 1 versus type 2. Treatment for hereditary angioedema has really gone a long way. Just, 5, maybe 10 years ago, we didn't really have much options, especially for treatment of pediatric patients with hereditary angioedema. the attenuated androgens were used for adults. Can't really use it for kids. It causes growth suppression and all that stuff. Virilization in girls. Aminocaproic acid wasn't really FDA approved, was really used in Europe. But now we've got plasma-derived C1 esterase protein, and that really is the treatment of choice now for hereditary angioedema. Very expensive, $350,000 a year and up. But it really has changed the lives of patients with hereditary angioedema. Other treatment options include bradykinin receptor antagonists like icatibant, and also kallikrein inhibitors like calantide. So not only do you give them the plasma-derived C1 esterase inhibitor, but you give them as-needed treatment with icatibant as well too for these patients. All right, asthma. I'm not going to go through asthma. I'm going to really breeze through it really quickly. You guys went through a whole entire section of pulmonary medicine. Just know that it's a chronic inflammatory disorder of the airways caused by reversible airway obstruction with recurrent episodes of cough, wheezing, chest tightness, and shortness of breath. That is really the crux of asthma. Okay. A nice thing to remember about asthma when you ask parents the rule of twos. Does your child have symptoms more than 2 times per week? Nightly symptoms more than 2 times per month? Need for albuterol more than 2 times per month? That way you can get a gauge of their impairment. The risk is how many times have they been in the emergency room or how many times they have been hospitalized because of their asthma. And there's a whole host of different treatments for asthma. I'm going to just kind of skip it because I think you guys have gone over it already. And there's biologics available now as well too, which is really fascinating. You've got something called omalizumab. Remember we talked about IgE and allergens causing mast cell degranulation via IgE. We've actually got a biologic that actually blocks IgE. And remember in the late phase, you've got recruitment of eosinophils that can cause the late phase of asthma. We've got something called mepolizumab, which can block IL-5, which is a cytokine that promotes the development of eosinophils. And then we've got something called dupilumab, which is anti-IL-4, IL-13. These are interleukins, which basically it's the language of allergic disease for the immune system. IL-4, IL-13 tell the immune system, oh, we got to have an allergic response. So if you block IL-4, IL-13, then you block that allergic response, in essence. Okay. Now, there's something that probably you didn't hear about. It's something called the Asthma Predictive Index. It's been around for a while, but it's really useful because before we had this, parents would kind of ask me, my child is wheezing. What's the likelihood of him having asthma? And I said, oh, I don't know. Maybe, maybe not. Who I don't know. But now, you can actually look to see what are their odds of having asthma. Okay, this predicts the likelihood of asthma in children who are too young to do any kind of objective lung function, who's had more than 4 episodes of wheezing per year. Okay. So there's 1 major criteria, 2 minor criteria, has a very nice predictive value of 95%, positive predictive value of 76%, and I'll show you how you can apply that in your practice. So the major criteria is if any one of the parents has asthma, or if the child has eczema, that's a major criteria. Minor criteria is if the child has allergic rhinitis, has wheezing apart from colds, and has eosinophilia. Right? So if you have any 1 major criteria or 2 minor criteria, then you've basically got a 76% chance of developing asthma when the child is 6 years of age. Okay? If you've got none of the criteria, then it's a negative predictive value of 95%. So at least you can kind of tell parents, what's the likelihood of their child developing asthma or not developing asthma. So moving on to rhinitis, there's allergic rhinitis, non-allergic rhinitis, vasomotor rhinitis, and rhinitis medicamentosa. We'll go over each one of these. All right, so with allergic rhinitis, you've got your seasonal type, right? These are caused by, seasonal pollination of, grass, tree, and weed pollens. You've got perennial allergens, which are kind of year-round, your dust mite allergy, mold allergy, animal dander allergy. All these patients will have the cardinal symptoms of nasal congestion, runny nose, sneezing, itchy all the time. This is IG mediated, and if you look on a nasal smear, you'll see eosinophils there, okay? So what will you see on your physical exam? You guys probably all see this. They've got these Denny Morgan lines, wrinkled, I believe, the eyes, allergic shiners, kind of like that darkened area beneath the eyes. You got this nasal salute. We're always doing this. They're always like itchy, and then that causes this transverse nasal crease that occurs, right? So those are kind of the stigmata of allergic disease. Right? If you look inside their nose, it's going to be swollen. It's going to be pale. Inside their throat, they're going to have some cobblestone from chronic postnasal drip. If you see polyps in a child's nose, that's very uncommon, and that you should think about other things like cystic fibrosis or allergic fungal sinusitis. All right, kids really shouldn't have nasal polyps in their nose. Okay, so we'll think about those two entities if you see nasal polyps. How do you treat? Well, avoidance. Right, you can do blood testing for allergies. You can send an allergy for skin testing. Antihistamines are kind of first-line therapy that parents usually try already, but nasal intranasal steroids are the most effective for nasal allergies. And of course, we can give allergy shots or allergen-specific immunotherapy, the AAAs. So what do you tell your parents in terms of avoidance? Well, you can tell them about the different seasons that things pollinate, right? So tree pollen is usually highest in the spring. Grass is usually in the summer. Weeds in the fall. Tell them to close their windows. Get HEPA air filtration systems. If they're allergic to dust mites, get impermeable mattress and pillow covers. Decrease the humidity to less than 50% because dust mites really thrive in high humidity. And make sure they wash their sheets in 140 degrees of hot water at least once a week to kill off the dust mites. If they're allergic to cat or dog, that's a tough one because usually if I tell them to get rid of their dog, they usually get rid of me first and their dogs. So I make do as best I can. I say, well, at least have Fluffy outside of their bedroom at the very least. So and get an air filtration system. Okay, there you go. So antihistamines, all right. So antihistamines, you got to worry about some of the early generation antihistamines that cause sedation. Okay, now kids can have kind of a paradoxical effect. I don't know if you noticed. So, like especially the younger kids, you give them like diphenhydramine, and they like go bonkers. They're like jumping off the walls instead of being more sedated. So that can happen as well too. And some of the older kids with the older generation antihistamines like diphenhydramine, chlorpheniramine, or hydroxyzine, they can cause sedation and things like that, and interacts with dopamine and serotonin in the brain, and can cause blurry vision, anticholinergic effects, and dry mouth. So we try to use more of the newer generation antihistamines like cetirizine, fexofenadine, loratadine, and so forth, which cause little to no sedation or paradoxical hyperactivity. Now, allergy shots, right? So allergy shots only work for IG-mediated conditions, okay? And what you have to do, what we do is you got to give increasing dosages over time so that they can build like tolerance to these antigens. I get a lot of times where parents come in and say, I want my son to get the allergy shot. And they say shot. I'm like, what do you mean shot? It's multiple shots, many shots, okay? And it's weekly shots. And then maybe 5 of them at a time, okay? And they're like, what? What do you mean? It is a regimen that we do over time to increase immune tolerance. So by doing that, you increase T regulatory cells. Remember we talked about those that suppress the immune system? So we get increase in those things. We get production of IL-10, TGF-beta. Remember, that's the language speak for suppressing the immune system, okay? And you also have these blocking antibodies, IgG, isotype to IgE, which helps kind of blunt the antigen's effects, okay? So that's allergy shots, okay, with an S, big S. All right. Non-allergic rhinitis with eosinophilia syndrome, or NARIS. These patients typically have chronic nasal congestion. You do a nasal smear, you'll see eosinophilia, but when you do allergy testing with them, it's all negative. Okay, so it's like a non-allergic rhinitis, so something to keep in mind. Vasomotor rhinitis occurs when patients have a reaction to neurogenic or vagal stimuli, okay? So examples of this is when it's cold, skiers' nose, they go outside, they get the runny nose. Some people, before they eat, their nose starts to dribble and runny. All right, they think it's an allergy. It's not an allergy. It's a neurogenic reflex cause of the rhinorrhea or nasal congestion. Okay. Rhinitis medicamentosa, this occurs when you get this rebound congestion by overusing vasoconstricting nasal drops. Fortunately, I don't see it too much in pediatrics. It's more of adults, and you can always make this diagnosis because these patients have like 5 bottles of like Afrin in their pocket, and like who carries 5 bottles of something, right? But they need it so bad they're using it 5, 6, 7, 8 times a day. So they're basically addicted to this, these drops. So phenylephrine, oxymetazoline, nafazolin, these are all things that can cause rhinitis medicamentosa. Treatment is discontinuation. You often have to put them on oral steroids in order to get them off of these things. A lot of times very difficult to treat. All right, food allergies. Food allergies affect about 6 to 8% of children. Now, unfortunately, probably next year I'll have to change the slide to 8 to 10%. For whatever reason, we're seeing an increase in food allergies and actually all atopic diseases in general. Food allergies are the leading cause of anaphylaxis outside of hospitals. It's pretty common in patients with atopic dermatitis. About a third of them will have a food allergy. Okay. What are the most common types of food allergies? 85% of the time, the kids are going to be allergic to wheat, eggs, milk and soy, peanuts and tree nuts, or shellfish. Okay, so those are the most common food allergens. Now, how do you make the diagnosis? Well, like anything else, it's history. Okay, allergy tests can only confirm if they're truly allergic. Okay. The reason for that is the allergy skin test and the allergy blood test have very low specificity, meaning that you get a lot of false positives, okay? And especially in children with eczema, you get a lot of false positives. Up to 50% of patients with eczema will have a positive allergy blood test, okay? So you gotta have a history that's consistent with a food allergy and then confirm it with an allergy test. Now, if it's negative, that's great. It has a very high sensitivity of more than 90%. So if they think they're allergic to something and the allergy skin test is negative, most likely they're not allergic to that food. But if you don't take the history into account and you just do random testing, you get a lot of false positives. Okay? And remember, I want to harp on this again, is the history is an IG-mediated reaction, right? So they eat the food, within a few minutes to at most 4 hours after eating the food, then they develop reactions, urticaria, angioedema, things like that, right? It's not going to be something that they eat for breakfast and they break out in a rash by dinner time, right? That's too long, okay? And it's definitely not going to be something where they eat it today and then tomorrow they break out in a rash. And that rash has nothing to do with the food that we eat. So we get that a lot of times that, oh, he's allergic to such and such. Well, when did he eat it? Well, today. And when did he actually get the rash? The following day. No, that's not going to be due to a food allergy, okay? And a lot of times people want food allergy testing, but however, when you do the allergy test, again, it's a very non-specific test and you get a lot of false positives, okay? Now, the blood test has a little bit less sensitivity than the skin prick test, although it's getting really good now. But the value is it does have certain cutoffs, okay, that has high positive prediction value. Unfortunately, they only have it for certain foods. So, for example, they only have it for eggs, milk, peanut, and codfish, meaning that, if you test somebody and their egg level is more than 7, there's about a 96-98% chance that person is actually clinically allergic to that food. Okay? But the problem is if it's lower, let's say it's a 3, it's a positive, but it's not quite above 7, what's your take on that? What's the end result of that? Unless you have the clinical history, that's the only way you really know. Okay? So sort of random indiscriminate testing is really not advised. All right. Now, the diagnosis, the gold standard is really the double-blind, placebo-controlled food challenge, but that's hard to do. A lot of times we just do just an open, single, non-blinded oral challenge. Treatment is with avoidance, epinephrine, okay? Now, I didn't include here because it's probably too new, but there's a lot of things in the news right now about desensitization, food desensitization in particular, and maybe parents might ask you about that. Just know that it's really experimental at this time, all right? A lot of studies have been done. Unfortunately, there's a lot of adverse reactions when they undergo the procedure for desensitization, anywhere from 30 to 50% adverse reactions, okay? And after you do it, it doesn't mean that you're cured of the food allergy. It just means that you have to take a little bit of that food every single day to prevent an accidental ingestion. Okay, so it's not a cure, it's just a desensitization where you can eat a little bit of it. You can't go to town and eat like a whole bunch of M&Ms or anything like that. You can only eat a little bit at a time. Okay, so something to keep in mind. All right, what's the natural history? Fortunately, most kids will outgrow their food allergies to cow's milk, egg, wheat, and soy, 85%. Unfortunately, most kids who are food allergic to shellfish, tree nuts, and peanuts, those tend to persist way until adulthood and beyond. So only about 20% of children will actually lose their sensitivity to those food items. Now, there's something called oral allergy syndrome that a lot of people have, and basically it's a localized food allergy syndrome. It mostly occurs with raw fruits and vegetables. So the way I kind of present it to parents and other patients is that it's kind of a very mild food allergy. The symptoms are confined to the lips, the mouth, and the throat. You almost never have like respiratory symptoms. Mostly it's all going to be just like tingling of the lips, itchiness on the roof of the mouth, and things like that. And because it's such a mild food allergy, these patients can tolerate cooked fruits and vegetables, but can't tolerate raw fruits and vegetables. Okay, so if they eat a raw apple, they'll get these symptoms. But if it's like apple pie that's been well cooked, then they can eat it just fine. Okay. All right, moving on to insect allergy. About 1% of children are going to have systemic reactions to insect stings, and the most common are from the Hymenoptera order. And these include, your bees, your yellow jackets, your wasps, okay, and your ants. If a child has had a previous reaction, okay, there's about a 10 to 15% chance of a risk of having a systemic reaction. And we know that venom allergy shots are very effective in preventing future systemic reactions, about 98% effective. So this table kind of looks at what happens if you've been stung or have not been stung, what the reaction was, and what's your risk of a future reaction in 10 years, okay? So if you have somebody who's never been stung whatsoever, okay, their risk, if they get stung in the future in 10 years, of having a systemic reaction is about 17%, all right? If you've been stung and you've got a large local reaction, your risk of having a systemic reaction if you're stung again is only 10%. So if you've been stung and you've got this large local reaction, you're actually protected versus the general population from having a systemic reaction if you get stung again, all right? If you're a child and you have just systemic cutaneous symptoms, what do I mean by that? If you get hives all over your body, okay? Your risk of having a systemic reaction is only 10%. In adults, it's about 20%. If you have anaphylaxis, all right, as a child, and you get stung again, you've got 40%. So it doesn't necessarily mean that if you got stung the first time, second time you're going to get anaphylaxis. It doesn't work that way. It's only about 40% that the second time you get stung, you're going to get a systemic reaction. If you're an adult, it's higher, it's 60%. So who gets immunotherapy? Who gets tested? Well, the only person who gets tested and gets immunotherapy is a child who's had anaphylaxis. Why? Because if you look at it, if the child got hives all over, that child's risk of having a systemic reaction in the future if they're stung again is only 10%. That's less than the general population. So it doesn't make sense to do anything for that child when their risk is actually lower than the general population. Does that kind of make sense? Yeah? So you only test, you only do venom immunotherapy when the child has anaphylaxis. Okay? So yeah, this basically just reiterates what I just said. You only refer to allergy only if the child has anaphylaxis to insect sting. Okay? Large local reactions, generalized hives do not require any further workup. It's because their risk is actually lower than the general population of getting a systemic reaction when they have a subsequent sting. All right, latex allergy. So natural rubber latex is made from the hevea tree. It's the most common cause of anaphylaxis in children and healthcare workers. Okay, certain populations are at high risk. All right. Kids with spina bifida, congenital urological problems, and a lot of manipulation or multiple surgeries, those are high risk of having latex allergy. It's an Ig-mediated phenomenon to the hevea protein. Now, interesting enough, there's a lot of cross-reactivity with multiple fruits and vegetables. Papaya, for example, kiwi, bananas, figs, potatoes, avocados, tomatoes, and chestnuts. So now I'm going to talk about adverse drug reactions. The WHO, or World Health Organization, defines adverse drug reactions as any noxious, unintended, or undesired effect of a drug that occurs as a dose used for prevention, diagnosis, or treatment. Cutaneous reactions are most common. About 15% of patients have some kind of adverse drug reaction while hospitalized, and about 7% have serious reactions. There's a lot of different types, right? There's type A, type B, different intolerances, idiosyncratic reaction, allergic. I'm going to focus just on allergic reactions for sake of time. And again, we use the Jelen-Coombs classification. So think about the time frame. When do these reactions occur, okay? So if it's immediate, okay, it's going to be your type 1 reaction. These reactions occur within minutes to hours of getting the drug, okay, because it's Ig-mediated, okay? It's caused by cross-linking of IgE and release of mediators from mast cells. You get urticaria, angioedema, or even full-blown anaphylaxis. Examples of this include, like penicillin, for example, okay? I'm going to spend some time about penicillin allergy because it is the most common drug allergy. Now, penicillin only cross-reacts with cephalosporin at a rate of maybe 1 to 3%, okay? So it's safe to give second and third generation cephalosporins to penicillin to patients with penicillin allergy. And maybe in the future data will even come out that cephalosporins, first generation cephalosporins are safe to give even in patients with penicillin allergy, okay? Now, if you have somebody who's pen allergic, all right, the option is to use a different medication. However, there are certain things that you have to give penicillin, then you do penicillin desensitization. So those include neurosyphilis, where that's the only and best option. If the patient has syphilis and is pregnant, okay, penicillin is the only choice, so you do desensitization. Or if you have a patient who has, maybe cystic fibrosis and they use a lot of antibiotics, so they've got a lot of multi-drug resistance, then penicillin desensitization is the treatment of choice. Your type 2 drug reactions or your cytotoxic reactions, okay, these occur days later, okay? What happens is IgM or IgG recognizes the drug antigen on the cell membrane, and when that happens, the antibody-coated cells are cleared by the monocyte macrophage system. So you can get, for example, if it's directed at red blood cells, you can have drug-induced hemolytic anemia, or if it's directed against platelets, and you can have autoimmune thrombocytopenia, okay? Some drugs that cause this include methodopa, penicillin, and cephalosporin. Your type 3 drug reactions occur 1 to 3 weeks after using that drug, right? This is immune complex mediated. Again, you've got these immune complexes that are formed. They deposit in your blood cell walls and cause injury. There's a complement cascade. These patients get fevers, rash, urticaria, lymphadenopathy, and arthralgias or arthritis. Example I gave before was with serum sickness, okay? And you can find these with medications such as ATG, thioluricil, and phenytoin. Okay. Your type 4 drug reaction, again, like all type 4 hypersensitive reactions, occur 48 to 72 hours later, is a delayed type. It's caused by drug-specific T cells they've been exposed to this drug before. Example of this would be, a contact dermatitis from your local antibiotics. Okay, very common is neomycin, for example. Patients put on the neomycin. A day, 2 or 3 days later, they get the rash from the neomycin from this type 4 delayed allergic reaction. So remember the time frame. The time frame is really important. Ask them, when did you take the medication? How long after you took the medication did you develop the symptoms? Now, vancomycin hypersensitivity, also known as red man syndrome or red child syndrome in this case, you have a constellation of symptoms including, itchiness, flushing, erythroderma, and it's really due to non-specific histamine release. Okay, that's rate dependent. So it corresponds to the amount of histamine that's released, and it has nothing to do with the vancomycin levels. You don't need to check the vancomycin levels. You just have to lower down the rate, okay, and then pre-med with antihistamines for vancomycin hypersensitivity. DRESS syndrome. All right, so DRESS syndrome, I like DRESS syndrome because it's kind of like ataxia telangiectasia. It kind of tells you what the patient's going to have, right? Drug reaction, eosinophilia with systemic symptoms, right? So they're going to have all those things. They're going to have this diffuse rash. They're going to have eosinophilia on their WBC diff, and they're going to have systemic involvement. They're going to have sometimes liver involvement, hepatitis, kidney involvement, sometimes lung, and sometimes cardiac involvement. The most notorious drugs that cause DRESS syndrome include your aromatic anticonvulsants, okay, like phenytoin. Sulfonamides do it, and allopurinol are huge ones as well too. They're associated with herpes virus 6 reactivation, and the treatment is just to stop the offending drug. You can give glucocorticosteroids plus or minus IVIG for treatment. Serum sickness, all right? So again, serum sickness, it's a type 3 immune complex reaction. It appears 1 to 3 weeks after administering the drug. Patients have fever, rashes, joint pain, lymphadenopathy, muscle aches, proteinuria. You kind of have this kind of classic serpentiginous rash, okay, on the hands and feet. There's arthralgias, arthritis, because you have immune complex deposition in the joint space. You can have glomerulonephritis from, again, immune complex in the glomeruli. You can have immune complexes in the GI tract causing nausea and vomiting and abdominal pain. Causes include equine anti-tetanus, antibiotics. Cephalosporin is a very common one, penicillin, ATG. Venom stings also can cause immune complex serum sickness reaction. All right, so now we're going to move on to mastocytosis. Now, mastocytosis is a really rare disorder. It's characterized by abnormal mast cell proliferation and accumulation. And there's different types of it depending on the degree of mast cells and organs involved. So you can have something just cutaneous, isolated cutaneous, and that's called urticaria pigmentosa. You can have systemic mastocytosis, and you can have malignant mastocytosis. Okay, so with cutaneous mastocytosis, there's more mast cells in the dermis, right? So this causes urticaria pigmentosa, and there's a neat sign where it's called Derrier sign. You've got this kind of brownish kind of macule on the skin of the patient, and just by stroking it, it causes formation of a wheal. So essentially what you're doing is you're causing mast cell release, and that's causing the formation of the wheal, basically a hive where that urticaria pigmentosa lesion is located. So you screen with something called a tryptase level, okay? One of the products of mast cell that is constantly produced is tryptase. So by looking at tryptase, you can kind of get an idea of how much mast cells are in the system. So if you've got high levels of tryptase, then you suspect a mast cell disorder. All right, and this is what the urticaria pigmentosa looks like, so this brownish, reddish kind of lesion. And what you do is, after you kind of stroke it gently, it urticates, okay? And that's because those mast cells that are all there on the skin release their contents, and you get that wheal and flare formation on the skin. And that's derriere sign. So kind of neat. Now, if you have mast cells not only on the skin, but in other tissues, you're going to have more symptoms, especially in the GI tract, liver tract. You have abdominal symptoms, fatigue, also anaphylaxis, a lot of GI symptoms from these patients, depending on how much mast cells are in other organ systems. And then finally, you can have malignant mastocytosis, basically where there is a cancer of mast cells, and you've got bone marrow that's producing a ton of mast cells. You typically don't have skin changes, but these patients are more sick. They've got hepatosplenomegaly, lymphadenopathy, and all the things that are associated with cancer. Treatment for these patients is avoiding extremes of heat, cold, and heat. Alcohol, aspirin, opiates, remember those are all direct mast cell degranulators, so you want to avoid those things. Oral cromolyn, a mast cell stabilizer, can help with the GI symptoms. For malignant mastocytosis and systemic mastocytosis, we try a lot of different chemotherapeutic agents. They're not very successful, unfortunately. All right, atopic dermatitis. So atopic dermatitis is a chronic relapsing inflammatory skin disease that's associated with allergy. It's the itch that rashes, right? So the crux of atopic dermatitis is really itch, and then you get the rash secondarily. So you really got to stop the itch. And a lot of patients will have this sort of atopic march where they have atopic dermatitis, they'll get allergies, and they ultimately get asthma. So that's the atopic march. Major features include itch, I mentioned that, chronic relapsing course. Okay, there's a typical distribution. In young children less than 2, it's usually on the face and extensor surfaces. Older kids, it's more on the flexural surfaces. Okay, there's usually a family history of atopic disease. How do you treat? Well, you treat by sort of this pyramid of treatment. You start at the bottom. The main thing is to moisturize. That's the key thing. You've got to moisturize these patients because studies have shown that there's actually a skin barrier problem for patients with atopic dermatitis, and they lose a lot of water content. So they constantly have to be moisturized up to 4, 5, 6 times a day. Okay, that is the very basic first step. And you can use a lot of different things, moisturizing creams, ointments, things like that to moisturize. But the key is actually to do it, especially after getting out of the bath. Within 5 minutes, you've got to moisturize the skin. Otherwise, you're going to lose all that water. It's going to cause more dryness of the skin. It's going to cause more itching, and you're going to go into this cycle. Okay. So I mentioned this already. You've got a lot of transepidermal loss. There's a scaffolding issue. Some patients have this what's called a filaggrin mutation. Filaggrin is this kind of scaffolding for the skin, and when you don't have this, you lose a lot of water, okay, content. So you constantly have to moisturize for these patients. Second line treatment is with immunosuppressants, topical corticosteroids, and also your pimecrolimus or tacrolimus, okay? Those are the mainstays of treatment after sufficient moisturization. Ointments are better than creams in terms of bioavailability, but they may be occlusive, especially during the heat. Okay, so sometimes creams may be better during the heat. Your topical calcineurin inhibitors are approved for children 2 and up. Okay, those include your tacrolimus and pimecrolimus. Okay. And what they do is they bind to FK506 binding protein, which is kind of an inflammatory protein. And by doing this, it inhibits signal transduction and gene transcription of pro-inflammatory mediators. So you kind of reduce that inflammation that occurs. So I found this has been very effective, especially for parents who are very steroid phobic, okay, for their children. And it doesn't cause skin thinning as well too. So you can use it, daily on the face. So that's where I found it very effective. All right, next line is antihistamines, okay? There's a scratch-itch cycle that you want to break, okay? The more they scratch, the more inflammation, the more it gets itchy, and then you kind of do this kind of cycle. Note that first-generation antihistamines are more effective in terms of itch reduction, but they do have sedative effects, or as we talked about earlier, actually paradoxical hypertensive effects. You should avoid topical antihistamines because you can get these children can get sensitized to the topical antihistamines. If the last three fail, you can also do wet wraps. They're very effective, and what they do is they cool the skin. They form a nice barrier, so they're not constantly scratching and causing trauma to the skin and causing more inflammation. Okay, so wet wraps are used. And then finally, the other thing that is that you could do are local antibiotics. If you suspect there might be an infection, okay, studies that show that for patients with atopic dermatitis, a lot of times they're colonized with Staph aureus, okay, 90% of them actually, in contrast to only about 5% of the normal population. And about 50% of this Staph aureus produce a superantigen, okay, called TSST1 that increases the inflammation that occurs on the skin. So by treating the Staph aureus, you reduce this inflammation. But that, of course, is a sort of a last resort because you don't want to build up resistance, okay? You can try like penicillins or first-generation cephalosporins. Topical antibiotics could be used, but you don't want to do it long-term because you don't want to, again, resistance and also MRSA colonization as well, too. So you want to do it for a short period of time, and that's it. All right, so a lot of your parents are going to ask you, especially if they have a sibling with allergies, what helps? How can I prevent my second child from having allergies? So let's look at the literature and let's see what actually helps. So number one, as we all know as pediatrician, breast is best, okay? And that's probably not going to change. Breastfeeding helps prevent allergies, okay? So that's number one. For high-risk patients, okay, who for whatever reason can't be breastfed, hydrolyzed formulas seem to help to prevent allergies. And then finally, earlier introductions of solids. Now this is a complete 180-degree turnaround from what we used to say before, right? Before we used to say, don't give cow's milk until 1 year of age. Don't give eggs until 2 years of age. Don't give nuts until 3 years of age. Now it's a complete turnaround. Actually introduce solids earlier, okay? I don't know if you guys have heard this already, but there's something called the LEAP study, which really changed what we thought about introduction of peanuts. In that study, the investigators found that if you start introducing peanuts earlier, 4 to 11 months of age, in high-risk infants, you actually reduce the incidence of peanut allergy by 80%, a huge number. So now what we're telling parents is, if they're neurologically ready to introduce peanut, now when I say peanut, it's like peanut butter, you want to make sure it's not a choking hazard, of course. But if you introduce it earlier, then it actually prevents the development of peanut food allergy in the future. Okay? And this is the LEAP study, actually. Here, this just came out in New England Journal in 2015. And as you can see there was a huge reduction in the consumption group versus the avoidance group for these infants with peanut allergy. And they did something called the Leap On study, where they, after 5 years of doing this, they oral challenged these kids to see if it was sustained. And the answer, it was sustained. So it wasn't just a temporary thing. You actually changed the natural history of these high-risk infants who were likely to develop peanut allergy. And they didn't if you introduced it early, 4 to 11 months in age. You got to give it a lot, though. You got to give at least 60 grams of peanut protein per week, okay, in order to prevent peanut allergy. All right. So, what does not help? Maternal restrictions during pregnancy. Doesn't do anything. Doesn't help at all. Delaying introduction of solids. Actually, that's the opposite. It actually may worsen things. So you don't want to do that. Giving soy-based formula, that doesn't work as well too. Doesn't help. Okay. All right. So we're done, and we're going to go over some questions now. All right. So get out your clickers, and we're going to go with question number 6. A 17-year-old boy has recurrent episodes of angioedema without urticaria. He has been admitted several times for abdominal pain. Previous treatment with epinephrine and steroids has had little effect. What workup should be done at this point to work up his condition? Should you A, check a C1 inhibitor level and function? Should you B, check a mannose binding lectin level and function? Should you C, check a C6 level? Or is it D, you should skin test to pollens? All right, very good. You guys got it right. So again, angioedema without urticaria, several episodes of abdominal pain. You want to think about hereditary angioedema. And a lot of times in kids, this is the exact age that they'll get picked up, because before puberty starts, the symptoms are very, very mild. A lot of times kids will get picked up for hereditary angioedema around the time of puberty. All right, next question. A 15-year-old girl is given a new medication for seizures. About 2 weeks after starting her medication, she begins having urticaria, fever, arthralgia, and malaise. What category of hypersensitivity reaction does her reaction fall into? Is it A, type 1? Is it B, type 2? Is it C, type 3? Or is it D, type 4? Very good. It is type 3. Remember, it's immune complex hypersensitivity reaction, so it's a type 3. And this patient is actually having serum sickness, okay? And it's very common with the aromatic anticonvulsants, okay? So she's having urticaria, fever, arthralgia, malaise. All that is immune complex mediate type 3. Good. Next question. A 5-year-old boy with a history of cardiac condition and peanut allergy comes in for well child care. After eating a candy bar, he starts to complain, develops hives and throat tightness. His mom informs you that he is taking carvedilol and digoxin. What is the most appropriate next step? Is it A, discontinue carvedilol? Is it B, give him diphenhydramine? Is it C, intramuscular epinephrine? Or is it D, intramuscular glucagon? Very good. You guys all got it right. Intramuscular epinephrine, right? Discontinue carvedilol in a high-risk patient of allergies, probably a good idea, but not what you want to do at the moment. You want to treat his anaphylaxis at the moment, right? So treating anaphylaxis, the first-line agent is epinephrine, epinephrine, epinephrine. Even though he's on carvedilol, a beta blocker, the first treatment is epinephrine. Very good. All right, 2 weeks ago, a 16-year-old boy comes to his physician with cough, sore throat, and runny nose. On physical exam, he has a fever of 101, mild pharyngeal erythema, small lymph nodes bilateral on his neck. His physician prescribes him amoxicillin for 2 weeks. After 7 days, he develops a morbilliform rash. What should be done next? Is it A, reassurance? Is it B, tell him he's allergic to amoxicillin and to avoid it in the future? Is it C, tell him he's allergic to all penicillin family drugs and to avoid them in the future? Or is it D, tell him he's allergic to penicillin and also to avoid cephalosporins due to cross-reactivity? Very good, 99%. You guys are awesome. Reassurance, remember? This is not going to be really due to an IG-mediated drug reaction occur like many, many days later. Just reassurance. That's all you need. Many times when you have a viral infection, you give amoxicillin, they're going to get a delayed rash from just the virus and the amoxicillin interaction. Okay, so just reassurance, that's all you need. All right, number 10. A 2-year-old boy presents with a history of recurrent abdominal pain, vomiting, flushing, and generalized red brownish macules. He has also had several hospitalizations for anaphylaxis. Which of the following tests would most likely yield the diagnosis? Is it A, skin testing? Is it B, tryptase level? Is it C, C1 inhibitor function? Or is it D, IgE level? Very good. It's tryptase level. So, his presentation, abdominal pain, vomiting, flushing, these brownish red macules. Think about systemic mastocytosis, and the screen for that is with a tryptase level. Very good. All right, 5-year-old boy with spina bifida has had multiple surgical procedures on his urinary tract and subsequently has developed a severe latex allergy. What is the most likely food he may be allergic to due to cross-reactivity with latex? Is it A, peach? Is it B, pear? Is it C, potato? Is it D, persimmon? Very good. Potato, that's the right answer. I really tried to trick you guys on this one because I put all peas on there and you guys still got it right, so good job. Potato, that's good. So that's the one that potato cross-reacts with latex. The other ones don't. Wow, that's really good. All right, number 12. A 4-year-old baby girl is seen by you for the first time. On exam, you notice that the umbilical cord is still attached. The baby has severe gingivitis and several abscesses on the gluteal area. What test would most likely yield the diagnosis? Is it A, dihydrorhodamine test? Is it B, nitroblue tetrazolium test? Is it C, flow cytometry for CD40? Or is it D, flow cytometry for CD18? Ooh, okay, this is a little bit, but you still got it right. Okay, most of you did, 55%. All right, so this baby girl comes for the first time, all right, and you notice the umbilical cord is still attached, has severe gingivitis and abscesses in the gluteal area. What are you guys mostly thinking of? Leukocyte adhesion defect, right? Because it's got the umbilical cord that's not attached, severe gingivitis, leukocyte adhesion defect, okay? Now, what is A for? Dihydrorhodamine test. What does that check for? Chronic granulomatous disease, right? So how does chronic granulomatous disease present? Now, it's going to have abscesses too, but it's not going to give you delayed separation of the umbilical cord. And you're going to have, septicemia with weird organisms like Chromobacterium, Burkholderia, Nocardia, and you're going to form like granulomas, right? So that's chronic granulomatous disease. This is leukocyte adhesion defect. So B, what is B going to test for? CGD, chronic granulomatous disease as well too, which is the old way we used to look at, try to test for it. Now that's the NBT test has been supplanted by the dihydrorhodamine test, okay? Now C, flow cytometry for CD40, that's going to check for hyper IgM syndrome, okay? So that's the one that's for hyper IgM syndrome. Those patients will have both sinopulmonary disease and they'll also be susceptible with PJP pneumonia because it's an inability for B cells to class switch. So they only produce IgM, they can't produce IgG. And also, you need that CD40 or CD40 ligand for T cells and macrophages to interact. And if the macrophages can't interact with the T cells, they can't fight off PJP infections. So flow cytometry, CD18, that's for a leukocyte adhesion defect. So that's the answer is D. Number 13. An 18-month-old boy was diagnosed with severe Epstein-Barr virus hepatitis 4 months ago. The boy returns 4 months later with fever, diffuse lymphadenopathy, weight loss, fatigue, and malaise. What is the most likely diagnosis? Is it A, ataxia telangiectasia? Is it B, X-linked lymphoproliferative syndrome? Is it C, Wiskott-Aldrich syndrome? Or is it D, autoimmune lymphoproliferative syndrome? Okay, good. So X-linked lymphoproliferative syndrome, that is correct. So these patients get hepatitis with fulminant hepatitis with EBV. They also can get bone marrow failure, and later on, because of EBV expansion, polygonal expansion of B cells, they can get lymphoma. So the correct answer is B, X-linked lymphoproliferative syndrome. D, autoimmune lymphoproliferative syndrome is something different, or ALPS. That causes diffuse lymphadenopathy, but it really doesn't cause the hepatitis like we see here with the X-linked lymphoproliferative syndrome. And also the autoimmune lymphoproliferative syndrome, those are actually benign lymphadenopathy. They don't progress to lymphomas, unlike the X-linked lymphoproliferative syndrome. Okay. Number 14. A 15-month-old boy with a history of eczema, thrombocytopenia, and recurrent infection comes in for his routine well child care. What vaccinations would be most appropriate at this time? Is it A, MMR, B, varicella? Is it C, live intranasal influenza? Or is it D, DTaP? Or E, OPV? Very good. 98% of you got it right. What's the diagnosis that you think? Wiskott-Aldrich syndrome. Very good. So primary immunodeficiency, they shouldn't get any live vaccines. The only one that's not a live vaccine on there is your DTaP. So that is the correct answer. 15. I think this is the last one. A 3-year-old boy presents with urinary retention, has a history of recurrent skin and organ abscesses that were culture positive for Burkholderia species. Which of the following tests would most likely yield the diagnosis? Is it A, flow cytometry for CD18, B, dihydrorhodamine test, C, peripheral smear showing giant granules, or is it D, genetic analysis showing STAT3 mutation? That is correct. Dihydrorhodamine test, 76% of you got it right. Remember that unusual organism, Burkholderia, recurrent organ abscesses. This is chronic granulomatous disease. This is the diagnosis you want to be thinking about. And to make the diagnosis, you do dihydrorhodamine test, okay? For C, the peripheral smear showing giant granules, that's for Shidak Higashi, right? So those patients have oculocutaneous albinism. They get also sinopulmonary infections, but it's different from obviously from the chronic granulomatous disease. 10-month-old infant who is seen by you for evaluation of neutropenia. Her absolute neutrophil count is 400. You check her absolute neutrophil count 3 weeks later, and it has risen to 2,000. She has a history of Pseudomonas sepsis. At the time of her infection, her absolute neutrophil count was documented at 400. What is the most likely diagnosis? Is it A, Kosman syndrome? Is it B, cyclic neutropenia? Is it C, severe chronic neutropenia? Or is it D, HIV? Very good. Pretty much all of you got it right. Her neutrophil counts change over time. There's a nadir, right? And then 3 weeks later, it's back to 2,000, back to being normal. So the correct answer is cyclic neutropenia. Okay. All right. 16-year-old girl presents with hives for the past 4 months. She complains of joint pain, general malaise that's not associated with heat or cold exposure, On physical exam, there's an erythemus wheal on the extremities, and on the abdomen, there's areas of hyperpigmentation, ecchymosis. What is the most likely diagnosis? Is it chronic idiopathic urticaria? Is it B, hereditary angioedema, urticaria? Is it C, urticarial vasculitis? Or is it D, familial cold urticaria? Very good. That is the correct answer. It's urticarial vasculitis. Remember, you want to worry about the red flags. If these joint pain, general malaise, they leave residual marks like ecchymosis, you want to think about urticarial vasculitis. Okay? Good. Number 18. A 14-year-old boy with asthma reports he's having cough for 3 days per week, for which he uses albuterol with relief. He has had 3 nighttime awakenings per month because of difficulty breathing. He is currently on low-dose inhaled corticosteroid and reports adherence to his medications. What is the most appropriate next step? Is it A, recommend continuing on the low-dose inhaled corticosteroid? Is it B, discontinue the low-dose inhaled corticosteroid and use albuterol only as needed? Is it C, change to a medium-dose inhaled corticosteroid? Or D, do you add a leukotriene receptor antagonist and continue the low-dose inhaled corticosteroid? All right, very good. That is the correct answer. This is a little tricky because a lot of people will add the leukotriene receptor inhibitor and continue the low dose, but that's not preferred. The preferred is to change to a medium dose inhaled corticosteroid, and you guys were not tricked by that, so really good. All right, 19. A 4-year-old developmentally delayed girl with silvery hair and hypopigmentation of the skin presents with frequent respiratory tract infections. What findings on a routine blood smear would be consistent with the diagnosis? Is it A, small platelets? Is it B, giant granules? Is it C, absence of color change with nitro blue tetrazolium dye? Or is it D, pronounced leukocytosis, WBCs more than 50,000? Excellent. That is the correct answer. This girl, your suspicion is going to be Shiragata Hagashi, right? Because of the occult-cutaneous albinism, frequent respiratory infections, you want to look for giant granules. That is the correct answer. Okay, number 20. A newborn comes to your office for a well baby visit. The parents are concerned because there is a strong family history of atopic disease. They would like to know how they can prevent the development of allergies in their newborn. According to the 2008 American Academy of Pediatric Guidelines, which of the following should you recommend? Is it A, the parent should delay the introduction of highly allergenic foods until 12 months of age? Is it B, parents should exclusively breastfeed the infant until more than 4 months of age? Is it C, the infant should be fed a soy-based infant formula to decrease the risk of cow's milk allergy? Or is it D, whether the infant develops atopic disease depends on what the mother ate during her pregnancy, so it's too late? And the answer is B. That's right. Breast is best. Thank you guys very much. Good luck to you guys. I know you guys are going to do awesome. Thank you very much.